விட்டு புலி வேட்டைக்கு சென்று அந்த புலியை கொன்று தானும் வீரமரணம் அடைந்திருப்பான். அந்த இளைஞனின் வீரத்தை போற்றி வைக்கப்பட்ட நடுக்கற்களே புலிக்குத்தி நடுக்கல் அல்லது புலிக்குத்திப்பட்டான் நடுக்கல் என வழங்கப்படுகின்றன. சேலம் அருங்காட்சியகத்தில் சேந்தமங்கலம் என்னும் ஊரிலிருந்து கொண்டு வரப்பட்ட 14ஆம் நூற்றாண்டை சேர்ந்த இரு புலிக்குத்தி நடுக்கற்கள் உள்ளன. அந்த நடுக்கல் உருவமே என் நினைவு பரிசில் குறிப்பிடப்பட்டுள்ளது. தமிழகம் முழுக்க இது போன்ற புலிக்குத்தி நடுக்கற்கள் தொல்லியல் மற்றும் வரலாற்று ஆய்வாளர்களால் ஆவணப்படுத்தப்பட்டுள்ளன. சேலம் குகை பகுதியில் புலிக்குத்தி தெரு என ஒரு தெருவின் பெயரே இன்றும் அமைந்துள்ளது. சேலத்து மண்ணின் வீரத்தினை பறைசாற்றும் நிகழ்கால சான்றாகும். சேலத்தின் வரலாற்று பெருமைகள் மற்றும் சிறப்புகளை நினைவு கூறும் வகையில் வடிவமைக்கப்பட்ட இந்நினைவு பரிசினை சிறப்பு விருந்தினர்களுக்கு வழங்குவதில் பெரும் உவகை கொள்கிறோம்.
Going into the session, today we are going to see oral cancer being persistent issue in our country. Our speaker, Dr. Prabdeep Kaur and Tejashree, Ms. Tejashree are here to give a talk about oral cancer screening in India, opportunities and challenges, a multi-site study. A few details about our speakers. Dr. Prabdeep Kaur, a physician and public health professional currently working as a chair and professor at Isaac Center for Public Health, Indian Institute of Science. She has 20 years of experience in epidemiological research, teaching and implementation science. Before joining Indian Institute of Science, she was a senior scientist, head of division of non-communicable diseases and course coordinator for the field epidemiology training centers. Fellowship program at Indian Council of Medical Research, Institute of Epidemiology, Chennai. She has published 90+ papers in national and international peer-reviewed journals and is part of several expert groups in public health. Ms. Tejashree, she is pursuing her doctoral studies at Data-Driven Decision-Making Lab, ECE, Indian Institute of Science. She has completed her Bachelor's of Engineering in Electronics and Communication Engineering from RNS Institute of Technology, Bengaluru. Her research interests are in artificial intelligence, machine learning, and statistical validation for healthcare applications.
Hello. Okay. Ellarkum vanakkam. Good morning. Very happy to be here. This is my favorite conference. I never miss it. Because I don't see this as a conference. It's more like coming back home and meeting all the friends. So this time I really thought that I should share with you a very unique topic, because we have been working very closely with the Directorate of Public Health, your team here, to do a very innovative work around oral cancer and artificial intelligence. So I'll be sort of walking you through the initial part of the work, and then my colleague Tejashree will specifically focus on the AI part of it. So as you know that, our NP-CDCS, which is now called NP-NCD, actually has 5 diseases. And we at Tamil Nadu under TNHSP, 4 diseases we started long back, way back from 2007-8. And then when the TNHSP expanded in 2011, we had the 4 diseases which were scaled up. But then under the national program, oral cancer screening was added. But in reality, the oral cancer screening is very low in India. If you look at NFHS data, the coverage is less than 1%. Literally, there is like no screening at all. But it is a highly preventable disease. So today I'll be focusing on that. It's an Indian problem. We have 1/3 of the oral cancer. Of all the oral cancer in the world, 1/3 are in India. And it's a cancer which can be easily detected because mouth is easy to access. Unlike many other organs where it's very difficult to know if cancer is there, you can see very easily. And the sad part is that 80% of the cancers are actually detected late. So 80% come late and hence survival is poor. But it's possible to reverse. You can detect 80% early and you can actually completely change the survival of people with oral cancer. So, but what can you do about that? So that is why the famous study which was done by Dr. Shankar Narayanan, I don't know if many of you know him, he recently passed away. His work showed, he did a very large trial and he showed that if people who are using tobacco, smoke less, smoking or alcohol, if you keep screening them, you can detect 70 to 80% of the oral cancer early. And you can detect it with the field healthcare workers. So there have been efforts to say, because it's possible to detect it in the mouth and because mouth is easily accessible, you can actually take pictures and with that you can actually make out whether it is, could be a cancerous lesion or not. So that's the background. So to keeping this in mind, so when, as you all know, I was at ICMR NI for most of my life and many of you have worked with me there. So last 2 years after I moved to IISc, my colleagues had started working on this on a very pilot basis, wherein they were trying to see, okay, can we develop an AI model which is able to detect this early cancer? So when I moved there, I told them that, see, we should do a much bigger study and develop and validate these models. And luckily we were fortunate that Ministry of Education at that time had a special grant which is focusing on healthcare applications of AI. And we got that grant, and under that grant, my colleagues, Professor Rajesh came last year, he couldn't come this year. So he and his team and several others, we started this study. And right from the beginning of this study, Tamil Nadu government has been our partner. So the objective of this study is actually to develop point-of-care AI-assisted white light-based mobile tool for oral cancer detection. And we also have sort of other objectives. But the idea is to develop it as a public good. So we could develop this AI tool and give it for free to government. Of course, there will be deployment cost, but there is no development cost for the governments. And we wanted to also validate this, not just develop, but validate, and validate with a fairly large sort of primary data. So I'll be telling you about that. So we have worked with two data sets. One is a secondary data set and the other is a primary data set. So when you do AI models, you can use existing data sets to develop your AI models. But then they need to be validated on a different data set. The data set you use to train and initially develop your model cannot be used to validate. So what we did, we first started working with an existing data set which came from Biocon Foundation. Biocon Foundation has been doing a lot of outreach screening programs for several years now, and in that process they had collected a huge data set of nearly 30,000 images. So we used this to develop the model, and then the ongoing study which I am telling you now about is the one where we are actually validating the model. So to take this image from the mouth, we had to develop an application because we have to actually record these images, right? So this is a mobile application which was developed by ISC. We have a Section 8 company, ArtPark. They are our partners in this. And it's a very simple application. You just need to open, put patient's name, age, gender, just put yes, no, tobacco use, alcohol use, because we want the image to be taken only for those people. And then you take image. So you have to take 8 images. And this study is going on currently in several, nine sites across 6 states. And in Tamil Nadu, Krishnagiri and Thanjavur are our study sites. So our goal was to enroll 12,000 plus participants across these 9 sites. And the sites are diverse. Some of these are actually cancer hospitals who do outreach programs. And the Tamil Nadu is in fact our only site where all the data is collected by the MLHPs at the field level. So it's very, very real time. And this is like the real public healthcare setting where this study is ongoing. So as you can see here, this is a picture from actually Krishnagiri. When we first started doing training, we trained the healthcare workers. They were really fast. They were able to learn it so fast. We were amazed that, you know, maybe it's the selfie culture that taking picture is no more considered a work. And in fact, they didn't like putting that age, gender and all that. They found that more problematic. But pictures, and we taught them how to take 8 images of mouth. And then they have to sync. It's an offline app. So whenever the network is there, they can sync these images. And as you can see here, this is then seen by telespecialist. So for us, telespecialist is the gold standard. That is, there is a standard reader who is a trained dental specialist who has seen, like, you know, oral cancer. And most of our, the trained readers are minimum 5+ years of experience. And here our partner, we have KLE Dental Sciences in Bangalore. Actually, they were the ones who were working in this area for a long time with Biocon Foundation, and they are our, they do the back-end reading of these images. So this is, I'm just going to focus a little bit on Tamil Nadu now, although it's a national study. So we found that if you look at the data from NFHS, and we have only 0.6% coverage of oral cancer screening in Krishnagiri and 2.2% in Thanjavur. Reason for choosing Thanjavur was Thanjavur has the highest incidence of oral cancer among women in India. So that's why we took it from the cancer registry, and that's how the site was selected in discussion with the NCD program and Director of Public Health. And as you can see, in Thanjavur, the overall, the tobacco consumption, especially among women, is higher than the other districts. So these are all the trainings from Thanjavur and Krishnagiri, and lot of field visits. We actually work closely with the nurses to understand whether, you know, it was possible for them to do it, what were the challenges on the ground. So this is from last year. We came for the Thanjavur conference, and we also did the field visit at that time. So now just to show you some data. So we are working on the 9 sites, and overall so far we have been able to enroll 28,000 individuals, and out of those 28,000 individuals, 7,800 had some suspicious lesion in the mouth, okay? So just to tell you that this is people who have either used tobacco or alcohol. So we are doing this screening only for the high-risk population, because that's what the trial which Shankar Narayanan did clearly showed, that oral cancer screening is not cost-effective if you do it general population. It's only cost-effective, and also it is effective if you do it in the high-risk group. So this is all high-risk group, and so this 27%, and then if you look at out of these 28,000, there are 1,100 which is called as high-risk lesions. So when you look at from the dental specialist, when they stratify anything in the mouth, so they stratify into 3 categories, normal or benign, and then suspicious is in 2 categories, low risk suspicious and high risk suspicious. And it is the high risk suspicious who can possibly be cancerous. They could be early cancer or can develop into cancer, and hence should be seen by ideally a specialist, and a biopsy should be done. So that number is around 3.9%. So just to give you a sense that if you screen 100 people, you will need to get at least 4 to the level where biopsy services are available. And this is, I'm just coming closer to home. If you look at Thanjavur and Krishnagiri, of course, because of the cancer registry data we have, I already told you that Thanjavur has higher incidence of oral cancer. That's what the cancer registry shows, and it is reflecting here also. As you can see, in Thanjavur, we got nearly 3% high-risk lesions compared to only 0.7% in Krishnagiri. So the yield of screening is very high in Thanjavur. And what I mean by high risk is these type of lesions: non-homogeneous leukoplakia, erythroplakia, varicose leukoplakia, proliferous varicose leukoplakia, and oral cancer. And if you go further into these high-risk lesions, you can see here in Thanjavur, we were actually able to pick quite a few cancers. Like these people were already at the time of screening actually having a squamous cell carcinoma. And you can see here, of the 154 individuals who were found to be high risk as per the images, this is the breakdown. 6 had malignancy, 4 had proliferative varicose leukoplakia, 3 had varicose leukoplakia, and there were no erythroplakia. But much lower number. As you can see here, we did not get this sort of more high-risk lesions in the and less detection of cancer in Krishnagiri. Just to drive home the point that the screening will be most useful in high-risk populations as far as oral cancer is concerned. And the other point I want to drive home is roughly 3 out of 100 will need to reach a place where biopsy is possible. So we really need to set the referral pathways before we begin this screening program at scale. So that is one of the learnings. And as you can see, this is overall. Here the cancer looks high for all the 9 sites because many of them are cancer hospitals where people are actually referred. So, and hence you do expect more cancers there. This is another important thing I want to highlight. So we wanted to see how common are these lesions in various risk groups so we can make a decision whom to screen. Okay, so if you can just focus more on the right side, which is actually for Thanjavur, the left is for Krishnagiri. And here you can see that there is, prevalence is much higher among people who have used smoking or smokeless tobacco, both men and women. It is 3 to 4%. We also looked at people who didn't smoke, but they used either areca nut or smokeless tobacco, and that group also it's 3 to 4%. So the yield is quite high among people who use this. And so what worked? We felt that we tried to document whether nurses could learn these skills fast. And as you can see here, the photograph taking was, it was very easy for them to learn. The time taken to complete the task among the younger healthcare workers, it was much less. For the older nurses, they took little bit more time to take the pictures. But generally, as you can see, it's not very time consuming. Whereas on the other hand, if you see the data entry, the older people, the older nurses struggled more to do the data entry. But even if you compare data entry versus taking photos, they found taking photos easier than entering the data. That was the general learning. So image capturing, we thought it will be a lot of problem, but strangely it was not a problem. Main thing is that our Tamil Nadu public health system is very well functioning. So it was easy to embed this intervention. We worked with the district and block medical officers were really good, and the nurses were able to quickly learn this skill. And we initially had the mobile application in English, but later we put Tamil as well. But they were fine with both. So the challenges were the referral pathway. We had a lot of difficulty in making sure these patients actually go to medical college for biopsy. So this is my request to the program manager and director of public health here. So if we want to scale this strategy, we really need to find a way, like there should be some patient navigation. We have to like navigate, make sure this patient actually goes. Otherwise screening is a waste of effort because these are like early cancer or can develop cancer patients. So some sort of navigation, some incentive might be required to make sure they actually reach the health facility. That was the main problem. And another big problem we felt, after a certain level, they could not find new people to be screened because there was certain people in the population who were willing to get screened, and that saturation, within 1 year itself, they reached the saturation, and they said, all those willing people we have already screened. We can't find more people. So although the coverage was not that high, but there was lack of willingness from people. So we need more awareness, and we also need that trust from people. You know, there's a fear that you will find cancer. So there was reluctance. And we hope that we can address these issues. Now I will let Tejashree tell you about the AI model. So using these images, we are validating the AI model, and she'll tell you a little more about it, and it will be actually ready for deployment by January 2026.
Good morning, Vanakkam to all. So today I'm going to talk about the
Dr.
artificial
Pradeep Kaur, ma'am.
intelligence models.
What happened? Yeah,
Ma'am, kindly we ask you to stay back on the dais, ma'am. Please be seated, ma'am.
Okay. Okay. So now I'm going to talk about the artificial intelligence models that we used for oral cancer screening in primary care in India. So the first part of my talk is going to be about the development of AI models, followed by how do we move these models from high-end computers to low compute devices such as smartphones, and then on why should we even trust AI. So coming to the data set that we use to train our models, as Dr. Kaur mentioned, we use the secondary data which was shared by Biocon. It consisted of about 30,000 images, and each image was labeled by a specialist, and it had an associated provisional diagnosis label, and the labels are there on the right side of the screen. So as Dr. Kaur mentioned, each image was categorized into non-suspicious, suspicious high risk, and suspicious low risk. So these are some of the examples: non-suspicious image, suspicious low risk lesion, and suspicious high risk lesion. Usually, in the traditional AI for healthcare applications, models such as diabetic retinopathy models and those used for analyzing lung CT scans, they're all very heavy. When I say heavy, they have hundreds of millions to even sometimes billions of parameters. They would need specialized hardware for them to operate. But in our case, we wanted to take our models and deploy it in a field. So we wanted to put it in a small device such as a smartphone so that it can be used by anyone. So such heavy AI models could not be deployed in our study. So we looked into models that was light in weight, and when I say light in weight, they would have approximately about 5 million parameters so that it can be easily embedded into any mobile application. So when we look at the data, whenever we are training AI models, we divide the data set into train set, validation set, and test set. So the images in the train set are those images that would help AI learn characteristics from. Validation set is the internal validation set that AI keeps checking during the training. And test set is a holdout set where we test the performance of AI once it is trained. So if we look at both train, validation as well as test set, the number of suspicious images is significantly lesser than the number of images in the non-suspicious class. So we had only about 16.5% of suspicious images and 83.5% of non-suspicious images in the entire data set. This is called as class imbalance, and it would affect AI's performance significantly because there are very few positive samples from which AI can learn. So we had to handle this issue, and the methods that we used to handle this issue was, one was based on sampling. So here what we do is we undersample the majority class so that the number of images in the majority class matches the number of images in the minority class. And the other method was a loss function based method where during training there is something called as loss function. That is, whenever AI misclassifies an image, we penalize it. And here we penalize it in a differentiated manner. So whenever AI misclassified a suspicious image, we gave a higher penalty. And whenever AI misclassified a non-suspicious image, the penalty was lesser. This way, we nudged the model so that it could learn the characteristics of the suspicious image in a better way. So here are the results. The baseline model, that is without doing any additional pre-processing, we were able to get an average sensitivity of about 75% and average specificity of about 90%. Because our intention was to build a screening tool, we wanted to increase the sensitivity, and with the methods that I just explained before, such as weighted cross entropy and data augmentations, such as flipping the image horizontally, vertically, and rotating it so that we add more variability in the data set, which would help the model generalize better. Using these methods, we were able to push the sensitivity to 85% as well as the specificity to 85%. So the highlights of this particular study is Class imbalance is inevitable. It is present in almost all kinds of data set, and it affects performance, especially sensitivity. So we need to come up with methods such as weighted loss functions and resampling based methods where we can handle this. And using all these methods, we will be able to get good performance. The best model that we were able to come up with had about 87% sensitivity as well as specificity. One thing that I would like to note here is, there was a recent study conducted by Birur et al. Where they mentioned that the frontline healthcare worker had about 60% sensitivity and 78% specificity in performing oral visual examination in comparison to a diagnosis given by a remote specialist. As we can compare the numbers, AI is significantly better in comparison to a frontline health worker. So right now we have the model, which is a lightweight AI model, but still it is sitting in the computer. What we want is to move it to a phone. And this does not come easily. There are a few challenges which I would like to highlight now. So as Dr. Kaur mentioned, we trained our model on a secondary data set that was shared by Biocon. All these data was collected in the period of 2011 to 2013. So the phones back then were quite different than the phones what we have now. So if we just look at the graph that I'm displaying there, on the left side, those are the red, green and blue channels of histograms of the secondary data set that was collected 10 years ago. And then on the right side, we can see similar waveforms for the data set that was collected as part of this study. As we can see, the shapes are quite different. If you just look at the blue curve, the peak is at somewhere around 80 in the older data set, and now it is around 150 in the newer data set. So these kind of changes that come from device specifications affect the performance. As we can see, the trained model performed very well on the older data set. It had about 85% sensitivity as well as specificity. But on the newer data set, it had poorer metrics, specifically 65% specificity as well as accuracy. This is poor and we need to improve it. Another challenge that comes up with newer phones is that earlier, the way how images were stored and the way how images were displayed on the phones was quite simple. Whatever you see is what it was stored in the backend. But now, the way images are displayed to the user and the way how they are stored in the backend are quite different. And we also had to account for all such device specifications. So we came up with a solution where we kind of normalized the effects that was coming from red, green, and blue channels through white balancing. And we introduced more augmentations, which was based on the metadata called as EXIF-based augmentations, which added more variability and helped the AI model be robust. So just one example, the image on the left, if you look at it, it looks a bit reddish, right? After the pre-processing, all those effects have been corrected for, and red, green, and blue, all the three channels have been put up at a mean of 128. With this, we were able to get good metrics, not just on the data set what AI had seen, but also on a newer data set that was collected by the latest phones. So as we can see here, the sensitivity, specificity, and accuracy was at 86%. And I would just like to remind that we were at 65% specificity when we started, but now we have reached to 86% specificity while holding on to the same 86% sensitivity. So the highlights are, models are usually trained on high-end GPUs, and we need to adapt them so that they can be implemented and deployed in low compute devices such as smartphones. And they need to be developed in a device agnostic way, such as each smartphone comes up with its own specification. Like most of you will have different smartphones, and if you try to capture the same image, all images would not look alike. They will be different. So we need to account for all these differences right during the model development cycle so that they can be easily deployed on any smartphone or any edge device. So there are certain techniques such as augmentations and pre-processing techniques which will help us do this and remove device dependencies to a larger extent. And standardizing image capture, such as putting minimal requirements on the kind of cameras and the resolution, and using flashlights during image capture. These are some things that will help us capture good quality images. Now we train the model on a high-end computer. Then we have also put it on the smartphone, and we are able to get good performance. But the question that would come was, can I trust AI? How do I believe it? How can I have confidence in it? So this section, I would like to talk about the interpretability of AI. So if you look at the left image, that is the actual original RGB image. And then just let us focus on the rightmost image. It is an image that has been annotated by the specialist. So the area that is marked in black is the area that the specialist has called as a lesion, high-risk lesion area. So now I want to understand, being a user of AI, I want to understand what are the regions that AI is looking at, or how AI is coming to a particular decision. So there are certain techniques called as GradCam++, where we try to understand in some sense what regions are contributing to AI's decision. So if we look at the middle image, this is the heat map of the model where the regions highlighted in red are the ones that are contributing to AI's decision. And if we compare the black region annotated by the specialist and the red region marked by the AI model, they are aligning almost perfectly. So this kind of techniques would enforce confidence and reliability in performance of AI, and it would ease AI adoption at scale. So what are the takeaways from this talk? So the first thing is, as we saw, AI has superior screening performance as compared to a frontline healthcare worker in doing physical, oral, visual examination. So it has strong potential in oral cancer screening applications as well as optimizing referrals. And for AI on the smartphone, or in other words, edge AI applications, we need to develop models in a device agnostic way so that they just not operate on one kind of phone, but all varieties of phones with different kind of camera specifications. And as I just showed one example where models have displayed good interpretability, where the model's decision is arriving from the same region where the specialist also looked at and called it as a suspicious lesion. With this, right now, based on the primary data that we collected from 9 sites across 6 states of India, we are going to perform a validation of AI in performance with human specialists. It's an ongoing study, and the results will be out soon. Then followed by a district-level implementation of the Arogya R01 app, along with the AI model. We are also very interested to see how the AI model behaves on the field. And as Dr. Kaur rightly emphasized on establishing the referral pathways, we also need to develop AI model to differentiate not just suspicious versus non-suspicious lesions, but also for a fine-grade risk detection based on the risk of converting it into a cancerous lesion. So we have come quite a distance, and there's much more to cover. And all of this could not have been possible without the support and collaboration of our partners across industry, academia, and the government. A special thank you to the Directorate of Public Health, Tamil Nadu, for the collaboration, without whom we couldn't have conducted all this study. With this, I would like to thank you.
The forum is open for questions.
Actually, it was a very good presentation. It's not a customary statement. Really, it throws some new insights, and also it looks very optimized, what can we say, feasible activity. And thanks for the compliment that Krishnagiri district was very responsive, and our health workers were able to capture what was intended to be done. Thank you. I have some doubts or clarification or questions which need not be answered right now, but for the sake of participants' knowledge, I wish to. When you showed it is 9.2 among 100,000 among women, the prevalence.
Sir, 4
It's
to 5% high risk.
high risk, and
Yeah.
9.2 per 100,000 women was one statistic from our.
I have to go back.
When you,
So
yeah, yeah.
basically, let me.
Because it looks very huge, because if you convert it as 10 per 100 lakh, and if it's 10 percentage
Not
is
cancer, sir. This
Ah.
is high risk lesions.
high risk lesions.
Yes,
But
yes.
even then,
3 to 4% is the prevalence of high risk lesions. Huh.
next.
Yeah. Can you please? Okay. Huh. Wait. I'll go.
Among women, this one.
No, sir. That is NFHS.
Uh,
This is not.
Okay.
This is from NFHS.
This is, I am talking about this. I just
Yeah.
want some clarification.
Yeah.
Oral cancer prevalence in Tanjavur women is 9.2 per 100,000 women.
Per 100,000, yes?
100,000.
Yes.
If
9.2
we
per
convert it for
100,000.
for
So
10,000.
this is from the cancer registry that Adyar
Yeah,
cancer.
I am not questioning the
Yeah.
prevalence or questioning your presentation. I'm just, I told you for the sake of
Yes,
participants.
yes.
I want to say that this, if you convert it for 10,000, it becomes 1 per 10,000 women. So 1 per 10,000 women seems to be very high, because we do not know undiagnosed. What about undiagnosed women?
Correct.
And how many of them will be at high risk and which will get themselves converted into a cancer cases? So this has some. It is shivering information actually.
Yes, sir.
So we have to be very cautious, and we have to look into this data.
Yes.
So, and another one is, are there any latest markers for oral cancer screening?
Okay, good question.
And
sir.
I will continue the questions, you can
Yeah, sure.
And how long does it take a smoker or a chewing tobacco to get converted into a precancerous or cancerous lesion? Because the age at which the smoking is initiated is 18 years, around 18 years in Tamil Nadu, particularly according to the GAT survey and NFHS. So it is worrisome. So if it takes 10 years for a cancer to manifest, or at least manifest as a precancerous lesion, then should we not include less than 30 in the screening population? And how long does a precancerous, whether it is homogeneous verrucous or non-homogeneous verrucous, to get converted into a cancerous lesion? And we are much concerned about the referral follow-up.
Yes.
So we were discussing with Dr. Manikam also. Probably he will be throwing some light. And when it is labeled by the screened AI attempt was confirmed by oral specialists, was there any incentive component to them? And was there any volunteering from the specialists? How did you recruit them? And what is the overall costing for a district? These are the things I want to know. Sir?
Yes. I'll answer few quick ones, sir. Regarding the markers, I mean, now with the NIH mess up, I don't know what's going to happen, but NIH was investing in a saliva-based marker in a big time, which is currently very costly. But there were studies going on, swish and spit. That is, if you just spit and then the biomarker can be done. But it's currently in the research mode, and it's also very expensive. So our colleague, Dr. Praveen Birur, who is one of our lead oral cancer specialist, is also working on that. But that won't come to practice in the near future. And that's the reason we actually reviewed all the interventions for oral cancer, and we found this is the easiest to scale up. And that's why we took, again, there are like different kind of imaging devices like fluorescent imaging and so on being tried. But white light is scalable because we don't need extra device for that. We can do it with the phone, and now everyone has smartphone. So that is the reason we looked at it. Regarding age, sir, we are actually analyzing data by age, and government currently recommends 30 years. And because, as you know, in cervical cancer, we say like it takes about 10 years to go to the cancerous phase. Similarly, you have worked a lot on cervical cancer. So I think same applies to oral cancer. Actually, there is a very prolonged precancerous phase. And even if there may be few people below 30 who can have precancerous lesion, but it will be very small. As you can say in Krishnagiri, where tobacco use is less, we are only getting high risk less than 1%. So if you go to younger age group, it will be even lower. I will just show you that.
Madam, one more additional question. Are there any information on the prevalence of oral cancer among non-risk cases? Any studies or any
Yes,
data?
sir. Yes.
So that we can whether we have to see, even though you just referred Dr. Sankar Narayanan
Yes.
was an expert,
Yes.
really we cannot deny or defy his statement.
Yeah.
But still then, what
Yes.
is the prevalence
So the
among
prevalence
non-risk?
is lower than this. That's what I'm coming to. So see, if you can see here, we are analyzing this data more carefully to see non-tobacco user but alcohol users. But we find the prevalence is very low. It's like 0.5. And if we take no alcohol, no tobacco, it will maybe even lower. It will be like too low for us to detect maybe in the screening program. So the reason why they said that it was cost effective to do it in this group was because, as you can see here, either smoking or smokeless tobacco, we are getting about 3 to 4% high risk, which is quite high actually. I mean, these are the people who are likely to become cancerous, or they may already be having cancer. So if we have to optimize our resources, we should first start with the high risk groups and first start with the above 30 years. And then if we feel that there are other people also can be screened, we can do, but that should be a second priority. We should optimize our screening. In fact, we can optimize for districts. The districts which have high tobacco use should be prioritized for the oral cancer screening program. And that is the reason we took Thanjavur. We discussed a lot with Dr. Selva about it. Actually, the Adyar has been pooling this cancer registry data for government of Tamil Nadu, and that's where we found this data. And that was a rationale. Krishnagiri we just chose, it was close to Bangalore. And it was easy for our team like Tejashri and others to go and see in the field how it is working. I think referral pathways, sir, we recommend that there should be what we have learned now. Even when we deploy AI, we need human in the loop. That is, when AI says high risk, that should be seen by a dentist, may not be instantaneously, but these images can be given access to a dentist at the district level who can be part of the public health department who is just reviewing these images. So it won't be a big workload. They need to only look at suspicious images. And then if they feel that they don't agree with the AI classification, they can always change the diagnosis. So we would like to experiment this as the next step. Have AI and then have human in the loop. What AI will take care is at the point of screening, quality is assured because now you have the image. It's not like someone is just seeing and making their own conclusion. And secondly, you are able to ensure that at least high risk people are getting picked up. Because nurse cannot find out who is high risk, who is low risk. Nurse is also finding it distinguishing like a pan-stained mouth versus a lesion. It's difficult to make out. So that part can be addressed by AI. But there should be human in the loop to make decisions. And just like we do in the TB program, we also propose that 5% of the negative images are also seen by a specialist, just to make sure that the AI is doing its job correctly. Yeah. Any more questions?
Thanks, Pradeep and Tejashri. I was in Kachar some time back.
Yeah, they are one of our sites.
So Ravi Kannan used to say, Ravi Kannan, who is the chief of Kachar Cancer Hospital, which is in a poor setting, there is a huge palliative program. So there is a home visit by the staff to take care of people who are very poor, don't have anything. So he used to say that we will do anything for patient.
Yeah.
We will do whatever it takes. But the reason I am pointing out, the more and more tools we have for detecting either cancer or other, what I am worried as an individual, as a citizen, is the care cascade.
Yeah, exactly.
So, I mean,
agree. Yeah.
it's good to detect with good sensitivity of 86, But then what happens to them subsequent to the deduction is what we need to be worried as part of the public health system. That's a concern to us. We should do something about it. We should strengthen our 104, some referral pathways, care cascade. Because what happens in Kachar, they say we will do anything for patient. Our load is huge. Our staff are very depleted. So when we bring in more tools, we should be conscious of the fact that we should bring more systems in place for taking care of the patients before it is too late for them. Thank you. It's not just a comment.
Yeah, I agree with you. Completely agree with you. Yes.
I have a question because this is actually generic to artificial intelligence in healthcare.
Yes.
But you are good people because you are in the front line to answer it. The problem of trust on AI as different from an individual is first that AI does not think, it pattern recognizes. So if you change the substrate as different from the trained program, it can make a mistake, which is all right. Even humans can make a mistake. But in AI, you cannot fix the mistake. One. And second reason, who is accountable for the mistake? Even Tesla has a huge problem with this, because if there is an automatic car which has an accident, is the software maker accountable or is the provider accountable, because the provider has gone by artificial intelligence? And if you do not have both correctability of mistake and the ability to hold accountability, how can you have trust? And essentially, all of healthcare is based on whatever the monetary exchange. You can't be sure that if you pay 1 lakh rupees for a treatment and
Question of accountability is much more. But my question here is that, see, in context of primary care, I mean, I am a public health person, I understand. See, our challenge is making sure that our thousands of staff are trained at the same level. For example, here I am talking about detecting an oral image. And to be honest, I am an MBBS doctor. I was not trained to detect an oral cancer, right? So I think it becomes very difficult to bring everybody to same level of training. And this is a good tool. See, if nurse uses and then she is getting an interpretation, it also helps her understand which images are being interpreted as suspicious, which images. So you can also look at indirectly a capacity building process. And wherever this assistance comes, you can always have a human in the loop who makes the decision, because you are referring. The final decision, whether it is cancerous or whether biopsy to be done, is again made by doctor and not by AI. But she will answer the first part. Go ahead. Yeah.
So for the first question, when you said AI cannot learn or correct, so the reason, I mean, that is partially correct, not entirely, because AI can always improve. The reason why we come up with so many augmentations or pre-processing methods is that we just don't assume this is an image, we just don't show it this way. We rotate it, we flip it, we add whatever kind of variability we can that can come from the real world, and then show it to the model so that it is kind of ready to what can happen, possibly happen on the field. And learning of AI never ceases. It keeps on learning. So it is also referred to as continual learning, that today AI is deployed and maybe after a month or so, on the new data that is collected, that data will become a part of the training data, and AI continues to learn from each and every new data set that keeps coming. So it's more like a human in the sense that, it's not a fixated knowledge. The knowledge, it can learn from its mistake, and there are new methods that are coming up day by day where we can address this issue of AI misclassifying, and day by day we are also improving our trust by interpretability tools that one of the tools I showed, GradCam++, but there are many such tools where interpretability of AI is presented in a visual manner so that there is more trust in the system.
So I'm just going to give some reflective comments, so don't feel compelled to answer. I think you're right that AI can improve as different from learn. If I have made a mistake in a single patient as a doctor and I get the feedback, I learn. AI doesn't do it that way. AI has to be trained on another set of material, it has to get through another process, and you can't quite say why the AI made the mistake. Because the algorithm, as different from machine learning, the algorithm is not transparent to you. So, I mean,
No, sir, just
this is a larger AI issue. You just look at
No,
it.
sir, I
It's
just
not,
want to clarify technically one issue.
you don't have to solve it here.
No,
I'm
sir.
just saying you must reflect that AI is inherently not a thinking machine.
No, sir.
It is a
the
pattern recognition
interpretability-
machine.
No. There is a difference. No, it's not
It is
correct,
not-
sir. I want to correct it because the interpretability of AI is a separate sort of learning, or you can say method in AI. The interpretability is what she showed you in the end, and it is that particular field is improving and growing. So we cannot say that it doesn't interpret.
So I'll keep my hope alive. It is
Yes.
improving and going.
No, but you cannot say
I
that
would
it
rather
doesn't
go with
interpret.
your other explanation that we are not leaving it to the machine, it is used as an assistant.
Yes, sir.
You have not yet counted in what the IAS officer may do. Okay, he may decide that he can go with the machine and lose the cadre. You can go with very simplistic interpretations of AI as labor saving is out there. You think you can reduce the number of radiologists. Actually, you need to increase. But there is also another trap with this assistance thing. If I am a very competent radiologist and or a dermatologist and I get this image, then I can see whether I will go by that image or whether my clinical sense will overrule it. If I am a very incompetent one, I will go with it. If I am an in-between one, I will do an in-between thing. My chances are that it will exaggerate and accelerate the difference in competency rather than build. These are cautions. Okay, in this, our job in public health is not to be cheerleaders of artificial intelligence. Our job is to have a critical outlook on the development of a new technology and how it will play out in a social context. And I'm not just talking of a thing. So when we talk of AI, yes, it will come. We can't, but we need cautions in many of these things.
Okay, thank you
For
very
want
much.
of-
And yeah, I think we are very happy that we were able to share this experience. I just want to summarize by saying that we cannot escape. If you just go outside, you use your facial recognition to get your photos in this conference. AI is there, it is here to stay. I as a public health professional have consciously decided to work with AI experts so that we can learn how to best use it to our advantage and make it work for us in the best possible scientific way. Thank you.
For want of time, we are moving on to the next session. If any further queries, we'll share their email IDs. Ma'am, please stay back on the stage, ma'am. We thank both our speakers. It was a very informative session. Now we invite the iconic jubilant and a vigilant observer, our Director of Public Health and Preventive Medicine, Dr. A. Somasundaram sir, onto the dais to honor our speakers. Dr. Pradeep Kaur, Professor, Indian Institute of Science, Bengaluru. Ms. Tejashri, Senior Research Fellow, EC Department, Indian Institute of Science, Bengaluru.
Thank you, sir. Assess, advise, agree, and assist. These are the 5 simplest action plan for tobacco control. Tamil Nadu can be considered a pioneer in tobacco control with the enforcement of CODPA. DPH Icon 2025 invites Dr. Avinash Sundlia, Deputy Assistant Director General, Ministry of Health and Family Welfare, Government of India, for an online session on Tamil Nadu tobacco control journey lessons to emulate. A few words on Sir. He is a public health professional with more than 11 years of experience, expert committee member in National Disaster Management Committee, expert member in Central Monitoring Committee for Biomedical Waste Management in India and International Health Regulations 2005. Welcome, sir.
So good morning to the participants of the DPHICon 2025. I am happy to be here. I think some issue is there from my side. I'm not able to put on my camera. So, of course, meetings like this, public health meetings like this are very important for knowledge sharing, collaborations, networking, and of course the deliberations which take place here. They're important for policy making and advocacy impact, and of course professional development of the public health professionals working all over. And it is important that the cross learnings which we take from here, they're important in improvising our future actions and how we can embark upon the future policies or the activities which we need to take, sort of a course correction or something like that. And yes, as public health professionals, we have an important responsibility in front of us in a way that it is our responsibility to see that the population, the human resource is utilized to the maximum. They don't land up into hospitals, and they're able to economically contribute to their family, to the community, and the society as a whole. So we need to embrace and strengthen the public health system in Tamil Nadu is concerned. There is a strong primary healthcare network foundation is there, and a lot of things are there which the other states they can take lessons from here. Apart from the robust maternal and child health services, the free drug initiatives, the whole lot of innovations, we often take lessons from here in the NHM component, and try to seek replicable models for the other this thing. So it is nice that DPH is doing a great job, and we are here to discuss on tobacco control today. Before I start discussing, let us try to understand as to why this particular topic was chosen and why this is having in a way, I would say, control the communicable diseases, and now the disease transition is towards the non-communicable diseases, NCDs. Tobacco is one of the important risk factors, and substance abuse, it has become a major public health concern all across. So all the more it becomes very important that we chalk out, we discuss upon the issue, what is the burden, what are the activities which we are currently doing, and how we need to work towards combating this menace. Tobacco, substance abuse, it affects the younger generation, so that is the future, so that is very important. It is one of the key risk factors. So primarily tobacco, alcohol, unhealthy diet, lack of physical activities, these are the four major risk factors for NCDs, and tobacco is one of the key risk factors. And apart from this, it does have an economic burden as well. So Tamil Nadu has been doing a great job in tobacco control since the inception of the program, and of course before that as well, since 2007 and 8 when it was started initially in first 2 districts. So let us try to understand what are the great things which we have seen here, and what we need to take across the learnings from. So next slide, please. Yeah. Actually, there is some issue with my video. I'm trying to put it on. So I think if I log out and then log in, I will be able to do it. So I don't want to do all that. Let us continue with this. So if we see the burden in the state of Tamil Nadu, we have the number of tobacco users in a way, urban, rural, and the total. So 20.1% in the males, and females it is around 5%. So this is state specific data. And yeah, so next. So this is the program structure, wherein there is a state tobacco control cell. Of course, it is there in every state. And here at the center, we have the National Tobacco Control Program. And from the state tobacco cell, it oversees the activities of the district tobacco control units. So we have district tobacco control units in almost all the districts of the state. And this is a great thing. It is one of the few states wherein we have these in all the districts. And they have been doing a great job, of course. The different components which are seen by the district tobacco control units are regarding the monitoring of the tobacco control laws, and of course reporting on our MIS portal, the training and capacity building. It includes healthcare, apart from the healthcare workers, of course, that goes on in other programs as well. It also includes training of the law enforcers who have to enforce our legislations. Then we have this IEC awareness. We have villages, schools. So all of that, it has to be popularized. Basically, in tobacco control, we have two groups of users. Two sets of people whom we try to address: users and non-users. So the users are basically those who have already been using the product. So more of a cessation, or we need to advocate with respect to why is it harmful, and how they can seek our cessation services. But for those who are non-users, that is particularly the youth, so we target them so as so they do not become future users. And for the information of the audience who are maybe they are not who are not the part of tobacco control, tobacco kills half of its users. So industry is always trying to find new users. So they have very innovative strategies, in a way how they will be attracting. They attract the new users, and how they this thing. So all of that goes in part of the IEC and school programs as well. So these are very important. And then, of course, the tobacco cessation for the tobacco users. So these are the activities which are undertaken by the district tobacco control units. Next, please. At the state tobacco control cell, so we have a legal team, and then the other staff, supportive staff is there, apart from the state nodal officer and the senior medical officer supporting the team. So we have the state nodal officer, Dr. K. Krishna Raj, currently looked after NCT as well. And there are a lot of, we've been motivated by the kind of initiatives and innovations we get from sir. And yeah, next please. So this is phase-wise strengthening of the tobacco control activities across. It started off initially, the program was piloted in 100 districts, and after that, so 2 districts were there in Tamil Nadu, 2008, and after that, in a phase-wise manner across the different districts, the district tobacco control cells, they have been established and strengthened, and today it is all across the state. Next, please. So let us discuss upon the few achievements and how they are crucial and important, and how they seek to address the issue of tobacco control. Next. So yeah. So first is ban on electronic cigarettes. So just for the information of the audience, electronic cigarettes are something which are banned in India in 2019, but this ban, it was initially, Tamil Nadu was one of the few states who initiated this, and In fact, in 2018 itself, 1 year before the Central Act came into this thing, it was banned. Now, what is electronic cigarette? They are trying to deliver nicotine directly. So, in tobacco, there are around 7,000 harmful chemicals. Out of this, one of them is nicotine, and it is nicotine is one of them is nicotine. So the e-cigarettes, they are trying to deliver nicotine directly to the user. So this is and of course nicotine is the product which is addictive. So that is why this is harmful. So it was banned here. This is one of the pioneer steps. Next, please. Second is the ban of hookah bars. So we have this central law, Cigarettes and Other Tobacco Products Act, code for 2003, and Tamil Nadu is one of the few states who have banned this hookah bars in the state by the way of amendment in the act. So Tamil Nadu Act 22 of 2023. So this is also a welcome state, and of course we always try to cite the example to the other states as well, that hookah bars, because in hookah bars also liquid form of nicotine, so similar way of e-cigarettes. So this is being given, and then it is also in a way to the other drugs. So the youth who are trying to use it, they also go on using it. They are also hooked to the other drugs. In a way, tobacco is the entry product for the other this thing. Next, please. Ban on smokeless tobacco. So this is something which is also innovative. Gutka and pan masala ban containing tobacco and nicotine. So this is banned here since 2013, and annual notifications are also, the latest renewal is effective from 23rd May 2025. So two types of products are there in tobacco: smokeless tobacco and smoking products. So smokeless tobacco ban is a very commendable achievement. And India, out of 27 crore users which are there in the country, 20 crores are the smokeless, which we call by the name of Gutka, Khania, and all those products. So this is something which is which is completely banned. So this ban in a way addresses the most of our problems, and of course I would say that lightens this thing. So lightens our burden in terms of enforcement as well. So this is one of our welcome steps, and I think we would encourage that the state continues with this. Next, please. Some of the key state laws and rules in Tamil Nadu: the Tamil Nadu Prohibition of Smoking and Spitting Act 2022. So this was also very effective, which prohibited smoking in places of public work or use. Then cigarettes and other tobacco. This was of course enforced completely in the state. So this particular law, it has broadly important 5 sections. Section 4, which is ban in smoking places, public places. This is very important, and it has been very effectively implemented. So this is something which is it is very heartening to note. Then of course the other sections wherein the schools, so educational institutions around 100 yards, availability of tobacco products within the 100 yards of the education. So this also has been very stringently enforced, and we have I would like to acknowledge and congratulate the tobacco control team there in TN, that we have enforcement squads in most of the states. So this is most of the state. So this is also one of the, and of course the civil society organizations are also effectively coordinating with the state and the district team. So this is something which is very notable. Then we have the direct and indirect advertisement of tobacco products. So this, and of course health warnings, of course they are being effectively implemented for all the local products which are being manufactured. Next, please. So these are some of the achievements over the years. Lot of fine which have been covered under the sections. I would not specifically take the name, the amount and all of that. Next, please. Next. So the total trainings and how much of capacity building has been done in terms of schools which have been declared tobacco free. So 50,000 schools have been declared tobacco free. Colleges, so around 2,200 plus colleges have been declared tobacco free. So this is a great achievement, of course. And continuously tobacco the state has been doing a lot more to increase the number. The number of people who have achieved tobacco cessation and beneficiaries. It is said that quitting tobacco is difficult. Only 3% of the tobacco users are able to quit, and of course it requires a lot of pursuance on the part of the counselors, and of course in advanced stages a sort of pharmacotherapy and all of that is also required. So this is a difficult activity, but that also has been effectively these things. And IEC campaigns, so anti-tobacco day celebrations, mass media campaigns, human chain signature campaigns, and all of these has been regularly done. And taking a cue from the state, we also have nationally now currently the third year running the youth campaign. So how specifically targeting the youth, we are having a tobacco free youth campaign nationwide. So this is something which is very notable. Next, please. These are some of the key challenges. Of course, every public health program has certain challenges. So these are a routine lack of awareness, because when the number of people who from the children, then they become to the youth and they become adults. So that lack of awareness. So awareness, of course, it is an ongoing activity in a public health program. So that, of course, has been done. Enforcement challenges, because transfers of the teams are happening and all of that. So that also needs to be strengthened. All of these are routine ongoing challenges which are and of course nicotine, actually e-cigarettes, that is this product, it is a challenge across the country. Actually, e-cigarettes which deliver nicotine directly, so that is something which is a point of concern. And I think the PECA Act, Central PECA Act, it has been, of course, been enforced effectively, and that good work, I think that needs to be continued. And just one more point which before I wind up, that Tamil Nadu is one of the leading states for the I think couple of years last, I think since the inception, as far as I am aware, they have been winning the Tobacco Free Youth Campaign award nationally, and one of the best performing states. So this is also something which is very inspiring for us and enthusiastic. And the team, they are trying to get their act together to address this important public health issue. So that is all from my side. Thank you.
Thank you, sir, for your insightful session. We are the state with a high number of field workers like VHN, MLHP, ASHAs, and WHVs of MTM. They directly work with the common people. Incorporating artificial intelligence for promoting the health of Tamil Nadu, we have a speaker who is going to strategize and plan the artificial intelligence in Tamil Nadu. DPHICon 2025 is well pleased to invite Dr. Sugan Chinnamaran, Operations Head, Tamil Nadu Apex Skill Development Center for Healthcare, Gindi, onto the dais. We welcome Dr. Sugan Chinnamaran, sir, onto the dais. A few words about Dr. Sugan Chinnamaran. He has led the development of first responder training, advanced life support, and digital health skilling. Spearheaded Memorandum of Understanding with key institutions such as the Tamil Nadu Dr. MGR Medical University and Gandhigram Rural Institute. He has built partnerships with over 200 hospitals and multiple academic bodies, ensuring TNASDCH remains a state and national leader in the healthcare skilling, training, and Tamil Nadu Apex Skill Development Center for Healthcare. DPHICon 2025 is well pleased to invite Mr. Ramesh Mahalingam, founder and CEO of Bains Healthcare. A few words about Mr. Ramesh Mahalingam. He brings over 30 years of experience as a technology leader in the United States. He is the founder of India's first artificial intelligence-powered hospital built on AI-first strategy to redefine the future of care. By identifying patient conditions far earlier than traditional methods, hospital ushers in a new era of preventive health care. Mr. Ramesh Mahalingam will be sharing his perspectives on the future of AI in global healthcare, including opportunities, risks, and challenges. Welcome Mr. Ramesh Mahalingam, sir, onto the dais to brief us a few words on the advancements in training of health workforce, artificial intelligence, and evaluation. Welcome, sir.
Hello. Good morning, everybody. Kami pannuma? Okay. No, I got it. Okay. So, good morning, everyone. And my name is Ramesh Mahalingam. And, as they had introduced, I don't know a whole lot about healthcare. Let me start off. I know there are a lot of experts in the healthcare field. And I have been a technologist for the past 30 years. And I've been a researcher in artificial intelligence for the past 20-25 years before AI has become a popularity, and I was very happy to listen to the previous speaker, Pradeep Kaur, and Tejasri's presentation, and extraordinary clarity in what they had presented, and very happy to also see how progressive our state has become. And I have now ஒரு 60 countries travel பண்ணியிருக்கேன். And I have to say, I'm very, very proud that our state is far progressive and far advanced, not necessarily in its technology capabilities, but also in understanding and being open to new ideas. And us being open is the foundation for advancement. So, with that, I've always thought, I always wondered why Tamil Nadu is advanced, is so progressive. Maybe the answer to that is our foundational Tirukkural of Noi Nadi, Noi Mudal Nadi, Adu Tanikkum, Vai Nadi, Vaippuச் செயல். இந்த மாதிரி ஒரு ஃபண்டமெண்டல் ஃபவுண்டேஷன் மாடல் ஆர்டிஃபிஷியல் இன்டெலிஜென்ஸால் கூட கொடுக்க முடியாது. பிகாஸ் ஒரு ப்ராப்ளமோட நோய் நாடி, நோய் முதல் நாடி, அதோட ரூட் காஸை கண்டுபிடிச்சு, வாய் நாடி வாய்ப்புச் செயல், then you actually figure out what the treatment should be. So maybe the reason we are so advanced is probably because we've had a much stronger foundation model from the likes of Thiruvalluvar. So with that, நாம் slideshow காட்டலாம், but what I would like to show is a sample of what we are doing in our AI-powered hospital. இப்போ AI-powered hospital அப்படின்னா it is becoming a it's a cliche or gimmick. இது என்ன எல்லாரும் சொல்கிற ஒரு மார்க்கெட்டிங் டேர்மா இது? Are there true value in artificial intelligence, and why should we do artificial intelligence powered hospital, and also why AI is unique in transforming healthcare? There are some fundamental questions, and I'm hoping in the next 20-25 minutes I'll be able to share at least my 2 cents. இதில் என்னோட credibility என்ன அப்படின்னா, as I had mentioned, I have about 30 years in this field, and I'm also I also have an investment firm. We've invested in about 14 different companies across the globe, mostly in the healthcare space, in epigenetic models and so on. So with that, I'll share why we wanted to create AI-powered hospital. We plan to have about 15 of these hospitals in the next 12 months. And the reason we wanted to create the AI-powered hospital is because no matter how much capabilities, how much technology is brought in, affordable care has become a problematic thing across the globe. Why is healthcare continuing to soar for patients? Why don't patients have affordable care? And this has been a haunting problem, because I travel across Africa also, a lot of different countries, a lot of governments, many cabinet ministers across the globe ask the same question. Why is technology unable to bring the cost of healthcare down for the patients? This is where I think the answer lies within artificial intelligence. Is there any fundamental difference? I think there was a gentleman actually asked a really good question, and I would like to address that as well, if I can. But the fundamental value of AI is, for the first time, a technology is challenging the knowledge economy. அதாவது இதுவரைக்கும் கம்ப்யூட்டர் ரெவல்யூஷன் வந்தபோது நம்ம கம்ப்யூட்டிங் கெப்பாசிட்டியை தான் சேலஞ்ச் பண்ணினோம். அதே மாதிரி மொபைல் டிரான்ஸ்ஃபர்மேஷன் வந்தபோது கம்யூனிகேஷன் மீடியமை சேலஞ்ச் பண்ணினோம். But artificial intelligence, for the first time, it is challenging the knowledge economy. And இதுவரைக்கும் நம்ம பண்ணியிருக்கிற டெக்னாலஜி ஓட total market பார்த்தோம்னா, it is only about $3 trillion. It's $3 trillion in the last 45 years. But in the next 3 years, artificial intelligence will become a $28 trillion market. So அப்படின்னா, every aspect of our day-to-day life will be driven and powered by artificial intelligence. Whether we like it or not, this is going to be the case. So why AI in healthcare? Why AI-powered hospital? There is a very fundamental reason. You see, healthcare has been...
Sir?
Yes.
Sorry to interrupt, sir.
Sure.
All delegates, please be seated. It is a very informative session. Please. Sir, thank you, sir.
Sure. Yes, actually, I hope this will be very informative, and please, I do request, spend a little bit of time in paying attention to it. See, artificial intelligence in healthcare uniquely is going to be transformative because of all the contributions of all the healthcare experts and specialists and doctors such as yourself. Because it is one of the most well documented domain in the world. So whether it is a disease, whether it is a treatment, whether it is a symptom, எந்த ஒரு விஷயமா இருந்தாலும் for the last 70 years, the doctors, the surgeons, the peer review journalists, everybody have actually done a phenomenal job of codifying it. எல்லாத்தையும் கோட் பண்ணி கரெக்டாக ஆர்கனைஸ் பண்ணி டாக்குமெண்ட் பண்ணதுனால artificial intelligence is uniquely placed to transform the healthcare industry. So the other industry that it has transformed is the programming industry. Same thing, the technology field has been well codified, so we have already been transformed. But this is very important. I wanted to actually stress the fact that artificial intelligence transformation in AI, artificial intelligence transformation is very, very critical for the healthcare industry. So with that, I want to show you a demo. I want to show a sample of how we are utilizing artificial intelligence to assist our nurses, to assist our doctors, to assist the surgeons, and how it is also playing an important role in training and providing continuous skills and training development for the healthcare practitioners. So I wanted to show one example of how and why we are an AI, we are trying to turn this into a fully AI-powered hospital. So with that, I'm going to quickly show, because I know the screen, the slideshow can be a little boring, but I want to make sure we have something that is a little bit more interactive. So I'm going to switch to a quick demo, and I'm going to show you some of the power of AI. So this is very, very important. This is not to showcase anything else. This is for us to actually understand what the future of healthcare might look like. So with that, let me quickly switch to a quick demo, and I'm going to ask a few questions and see how artificial intelligence is handling it. Now, at any given time, again, towards the end, any question, please feel free to ask. And give me a second. So this is one piece of segment within our hospital. So in the Mari, we have similar segments within our hospital, where, as I had mentioned, nurses, doctors, surgeons, they all interact with the AI system, and then AI actually provides the proper guidance. A very important thing is that the AI engine adapts to the audience themselves. So, for instance, ஒரு nurse interact பண்றாங்க அப்படின்னா, the AI model has the ability to adapt to the persona of the nurse, and it will actually have the ability to communicate with them in that model. So if you really think about skills training, for instance, the skills training problem, there is a fundamental shortage of skills, and then there is a fundamental shortage of knowledge. How much can nurses ask a question? How much insight they can get? How deep can the insights be? How much guidance they can get? So there is a significant problem in the shortage of skills when it comes to training competent nurses and junior doctors who are coming into the field. So what we had done is we have created simulated cases for many of the patients, and then we allow the staff to actually ask questions and gain more insight by interacting with the patients. So let's first, I'm going to show you a sample example of how it's going to function. And let's see. Hi. Are you available?
Yes, I'm here. How can I assist you with Maya's care right now?
Can you explain Maya's heart rate, please?
Maya's blood sugar level is currently elevated. Her fasting blood sugar was recorded. Her fasting blood glucose is. Maya's blood sugar is 1.
Do you see do you see any concern with her elevations?
Sure. Based on Maya's blood glucose levels, she's showing hyperglycemia. Her fasting blood sugar is elevated at 142 milligrams deciliter.
அவங்களோட glucose level என்ன இருக்கு?
Her blood glucose level
அது
is
தமிழ்ல
slightly
சொல்லுங்க.
elevated, which is common post-operative.
Can you say it in Tamil?
Her blood glucose of 162 milligrams deciliter is above the normal fasting.
Hello, are you
range.
listening?
Overall, her blood glucose level.
Maya Deviyoda blood glucose level எவ்வளவு இருக்கு?
Maya's oxygen saturation is currently 90%, which is a bit low. We want to aim for at least 94% or higher. We could consider adjusting her oxygen therapy.
So,
कुल मिलाकर ये संकेत में अभी उनका स्पोटू 90% है, जो थोड़ा कम है. हमें ऑक्सीजन सपोर्ट बढ़ाने या पुनर्मूल्यांकन करने.
No, that's good. Hold on. Can you pause?
इन चीजों पर
Can you explain the piperacillin tazobactam?
अभी उनका ब्लड ग्लूकोज लेवल 1.
Hello?
Hello, how can I assist you? Sure.
Can you explain piperacillin tazobactam?
Piperacillin tazobactam is a broad-spectrum antibiotic. Sure. Piperacillin tazobactam.
Sorry, the problem is there is a significant noise in the environment. So every time there is a noise, that is, and the echo varudhanala, it keeps going into a loop. So bear with me on that in this noise level. It's significant noise here, but let's continue to do it. Yeah, can you explain the piperacillin tazobactam, please?
Piperacillin tazobactam is a combination antibiotic. Piperacillin is a penicillin-type antibiotic that works by killing bacteria, and tazobactam is a beta-lactamase inhibitor.
Can you pause?
Piperacillin tazobactam is a broad spectrum.
So what we end up actually doing here is when we ask a question, it is not just a question of just responding to the question. You can actually gain lot more insight from the AI system as you're conversing. In fact, even with the noise level, it is actually quite impressive because generally number situation it has to be in a closed environment where the doctors are actually interacting. It is not on such a massive decibel level right now what we have. But even with that, it is significantly impressive. So so how do you interpret the GCS level for Maya Devi?
It looks like the Glasgow Coma Scale GCS wasn't recorded properly in the system. Could you share the page? Got it. The Glasgow Coma Scale isn't recorded properly right now. Could you confirm the patient's eye, verbal, and motor responses for a more accurate GCS score?
And what's her temperature level?
Sure. Right now, Maya's oxygen saturation is at 90%, which is on the lower side. We should monitor her breathing closely.
And what's her temperature?
Sure, take your time. I'll check back in a moment to see if you're ready to continue.
Yeah, I kind of expected it because of the significant noise level. இது என்ன ஆகுதுன்னா, more and more it's listening to somebody else's noise, it is actually responding back. Oh, 5 minutes left. So, um, the important thing to note is that we are utilizing this assistant for nurses. We are using it in the doctor stations. We are using it in the surgeon stations. So, essentially, the artificial assistant across the entire hospital is being utilized, and we expect to have this as the core baseline. One of the questions that I wanted to address to the gentleman's request is that, is artificial intelligence going to be the decision maker within the hospital? And that is never going to be true. Hospital setup la, artificial intelligence is going to be merely a companion. It is about assisting them to know if there are any alerts, any significant elevation, any challenges that it sees. To one of the important questions that was asked is, who is accountable? It's one of the important questions gentleman actually asked. It's a very important question and it has to be addressed. No matter what happens, AI will continue to be just a tool. Now, if we allow the tool to run without an oversight, the accountability still lies with the people. So you can never take humans out of the loop, but what it does is it relieves significant stress and the burden of the healthcare workers. So this would be a very important companion. And so there is, I know I'm quickly running out of time, but if you want to actually see a demo on a quieter environment, I'll be happy to do so. But the AI-powered hospital, the vision of the AI-powered hospital is that from pharmacy prescription to the diagnostics lab, to our ICU monitoring, as well as the surgical process, we have actually enabled this AI assistance across the board. The power of having artificial intelligence here is that it will continue to adapt to the persona, and because of that, the healthcare team can be trained, they can be continued to be upskilled. So this is an experiment. Certainly, idha modal vaati try pandrom. What will the experiment really result? We don't know. But we expect to have about 12 of such hospitals that will be fully powered by artificial intelligence. And probably by the end of January, we'll have clear results as to how the AI-powered hospitals will fare. So far in the first hospital, it has done extremely well. And most importantly, we have been able to reduce the cost of health per patient so far by about 18%. So about 18% of cost, we have handed it back to the patients because we were able to optimize it through the AI models. So we hope to actually reach about 30 to 32% in the next 6 months. So across 18 hospitals, if AI as a companion is able to reduce the cost of healthcare by 22%, we think our goal would be accomplished. So we will know in the next 3 to 4 months. So I think I have run out of time, but I'm happy to field any questions that you may have regarding the AI or any challenges with respect to AI.
Thank you, sir. That was a very informative session. Now we call our Joint Director, Communicable Disease, Dr. Sendil Kumar sir, onto the dais to felicitate our speakers. Mr. Ramesh Mahalingam, founder and CEO, Bains Healthcare. Dr. Sugan Chinnamaran, Operations Head, Tamil Nadu Apex Skill Development Center for Healthcare, Guindy. Going on to the next session, we all know what a pandemic is, as we are all well aware of it in the past. Now, our speaker, Dr. Sundar Raman sir, former chair HTA in Technical Advisory Committee, 22 years of Faculty of Internal Medicine, JIPMER in Puducherry, currently chair of Technical Advisory Committee for Health Technology Assessment of the Department of Health Research, Government of India, is here to talk about the Global Pandemic Agreement, Consensus and Contestations.
Right. Thank you. I always felt it an honor to be in this rather unique conference. A huge public health audience of the public health community at its best in one of the best practicing states. This is my 4th year here and I've enjoyed every minute of it. So I echo this and thank you for this. I thought this time when all of you are public health people who are focused on the very, very local problems, I would use this opportunity to take you across what is happening in the world where global health, global public health has never been more active as of today. In fact, just yesterday, there has been at the UN a confrontation on non-communicable diseases, nothing less, where the US has walked out of signing on the declaration and it has been referred to the General Assembly. So it's never been such a hot topic at the global level. I think it's important that we have a look at this. Now, why must this hall, why must all of you get interested in a topic like this? Because in a very unusual degree of coordination, or let us say influence, global policies influence national policies, and through national policies health in a way in which it does not happen in any other sector. So if the tuberculosis strategy changes to dots, then everybody is doing dots. Then in 2014 they say no dots, and then everybody is not doing dots. Then they say we are going to do TPT, treatment for preventive treatment for tuberculosis, then everybody is doing that. Or in HIV, or in international health regulations, on a day-to-day basis, much of what you do is decided at the global level. And the global decisions are not purely technical public health. They are intensively political decisions. Just like you just see what is happening in the United Nations General Assembly on non-communicable disease on the last 2 days. Yesterday and today, if you are following the papers on that. And the public health community must engage in making public health policies. It is not just, we should not see ourselves as just people who go abroad and take training and come here and give that training. We are not passive channels. We are active thinkers in this particular area. And unless you have a critical appreciation of global health policies, you cannot anticipate how they will play out in Tamil Nadu. You cannot mitigate the problems they create. You cannot adapt those policies to your needs. And you must see it in its contestations. Something that comes as the absolute truth may have won by one vote at the center. So in some sense, the consensus is a working consensus. And perhaps one of the best areas to see this is in the study of the international health regulation and the pandemic agreements, where you can get a sector of who are the stakeholders in policy, what are the issues, what is the conflicts about, and what a development country needs to do for ensuring health systems resilience. I must thank you for using that term as the theme of this conference, resilient health systems. I don't think we have explored it enough, but I think there is a lot to be said. But along with it, health security, health sovereignty, health equity, health outcomes, all of these are in very active contestation on this. Now, why has this become so topical? You know, it's so surprising. The greatest public health event of our lifetimes and perhaps of the century has just happened 3 years back. Never was public health and so intrusive into the lives of everybody, whether they were literate or non-literate, health or non-health. Yet, the world has collectively forgotten a lot of it. And it is important that we learn. I don't even know whether, if you ask a question, did night curfews that we imposed during COVID-19 pandemic, did they reduce the transmission of the virus? We don't have a public health answer to many of these questions. We do not even have enough follow-up research on the greatest public health event of our times. And it was a major setback to poverty elimination goals. There is a rise in inequity. There is a rise in authoritarianism across countries that the pandemic set in motion. And there is a new positive side, a new awareness that healthcare, including vaccines, must be seen as global public goods. And this famous statement, no one is safe unless everyone is safe. And the collateral of that is no country can make itself safe unless all countries are safe. And this sense of solidarity is very important. And the experience of the last pandemic, when LMICs received very little help, very little was promised and even less was delivered. And the recognition repeatedly said that this is not the last pandemic this century will see. There will be more pandemics and they are likely to be things. So these were the drivers why by 2022, after the second wave, everybody seriously got into making these new instruments. Now, for the public health youngsters over here, for me, I think most of you are youngsters other than the first 2 or 3 rows. I think you need to understand this difference in word between the declarations, regulations, treaties, agreements and conventions. International declarations are non-binding declarations, but they have a lot of moral power. You align a lot of what you do in the state government health policy looking at the declarations. Regulations are decided by a simple majority, but countries can opt out. But once it's declared, it's binding on everybody who has ratified it. But agreements under Article 19, this is of the WHO Constitution, need ratification by individual countries, and at least 60 countries must ratify for it to go into effect. So the international health regulations is under Article 21, was adopted in 2005. That was a history, International Phytosanitary Code, etc. But amended in World Health Assembly 77 in 2024, and these amendments come into force in the whole world, including Tamil Nadu, from last week, from 1 week back. These amendments are in force. What have you done differently is a question that you must ask, but these have just come into force. And the pandemic agreement adopted in World Health Assembly 78 in May 2005 is to be put up for ratification after 2026 and may come into force later. So in terms of global policy, these are some of the most significant events that have happened in your time. Yet, how many people would be familiar with what is the content of these public health policies? You are all public health people. Can I see a show of hands? I don't seriously expect to see, but I am happy to see some hands go up. These are important for you to know. You can't really carry off your credibility in the public health world without that. Now, these amendments went through with a consensus. That's great news. A large consensus. One of the first things it did was to change the definition of a pandemic emergency. Before, you needed 70 countries to have the pandemic. You had what was called a public health emergency of international concern, which was what was declared by the DG in January 30th of 2020. But the pandemic was declared in March when it had spread to so many countries, by which time it was already too late. And therefore, the definition of pandemic emergency has been changed, and this has got included in IHR wherever you are saying public health emergency of international concern and pandemic emergencies. So this definition, I'm not going to go into that, you'll have to read it up, goes along with creating a national health authority for this control and a focal point, accelerated sharing of information, and the process for declaration of a pandemic emergency. All of these were modified by the amendment. Article 13 is important. It gave the WHO the mandate to coordinate an international response with a commitment to help countries which are not able to respond by themselves. It gave them a mandate to remove barriers to international access, promote local production, and countries to support WHO. It created a coordinating financial mechanism and established state party committees. However, it must be noted that though we say there is a consensus, this by itself fell short of what is required to make it safe. In what way? There is no obligation on developed countries which have a monopoly on technology and on finances to cooperate. It is voluntary, both on companies and on countries. The mandate only enables WHO, but there is little that WHO can do without the major countries. And finally, when it came to ratifying, 11 countries used the opt-out clause. So in this opt-out, the USA, Israel, they are known suspects. They opted out first. But even Germany, Canada, and Netherlands have opted out. Switzerland has put a reserve. And these are many of the countries which are the front line in technology development. So you can see that there has been a high degree of reluctance from the companies of the world to actually corporations of the world to... Okay, you have 10 minutes. Okay. Now the pandemic agreement has a much wider scope. The pandemic agreement is to ensure prevention, preparedness, and response. It comes with an understanding without coordinated action on the global scale, pandemics of this scale are likely to occur even more frequently. It had 13 meetings, an international governing meeting. Many meetings went late into the night. It was seriously discussed. There were many issues of public health concerns. And finally, an agreement was thrashed out. It's a sort of compromised argument on May 2025. But it's still under discussion. In fact, this week, last week, while you are meeting here, there is a meeting occurring by the International Government Working Group to finalize the pathogen access and benefit sharing part of the thing. And even after ratification is long, fortunately, there is also 3 clauses that says in anticipation of its ratifications, voluntarily countries should start implementing these things as if it has got passed. And this is something that progressive states like Tamil Nadu must use, because there is a whole lot of good understanding in this, though which may be contested by big pharmaceuticals and international multinational corporations, is in our interest to actually pursue. What are the main gains of this? The main gains are the acceptance of certain principles. It's a sovereign right, sovereignty. dignity, human rights, humanitarian law, and most important, the thing that Donald Trump is most angry with. Whatever he is angry with is possibly good for us. Okay, and in one of the things he's angry with is these words equity and solidarity. You know, he has gone on record saying, I don't understand what this word solidarity means. Okay, I hope your public health course teaches you the importance of solidarity as a fundamental principle of healthcare internationally and nationally. So solidarity and the best available science and evidence to govern policies. So the acceptance of these principles as the governing principles was itself a major struggle. And there is what we say, kick the can down the road. There is a number of institutions that have to be followed to make it work. Now, Article 4 is about preventive measures. And if you look at Tamil Nadu, there are certain areas where you're good, but there are certain areas where you're really not so good, and there are certain areas which are startup areas that you need. But the problem at the international level, where the argument was when it came to financial support, and can all countries which have other priorities prioritize these sort of surveillance over other surveillance that they need? So there are a lot of things, and these structural determinants require other things to change. Article 5 is One Health. It represents a big gain in that One Health is now part of an international treaty. It is part of an international agreement. But again, when it came to what are the measures at implementation, there was such a contestation that the final conclusion is rather broadly stated. One has to work out what it will actually mean in terms of the standards which will be set and which will be adhered to. Article 6 is particularly important, and I wish your finance secretary is here in the room to listen to this, because it talks about resilience being primary health care for pandemic prevention, preparedness and response, taking into account the need. In effect, when you are talking of preparedness, to just summarize, what you need is an accelerated access to universal health coverage with an entire access to primary health care as an entitlement. The acceptance of that in a treaty is important, and you need information systems and periodic reporting for that. And then there is a very good section on the rights and terms of the health workforce. So the way you use these acts is to argue with your political leadership. The public health community has a responsibility here to argue with your political leadership and your administrative leadership to align yourself with the best thinking on this at the global level. The concerns are that while Article 4 to 7 require an accelerated achievement of universal health care, most LMICs are far from doing it, including Tamil Nadu, because of a very selective prioritization approach. Even NCDs is reduced to 4 diseases, which is not an appropriate definition for NCDs. And there are pressures to shift over to purchasing care from private sector. So there is a flaw in the overall roadmaps to UHC that needs to be addressed. And one of the main instruments of even communicating IHR and pandemic agreement and getting alignment with it is the WHO, which the WHO is itself getting weakened. I saw yesterday, for example, the withdrawal of the polio surveillance units across India and saying we leave it to states to take it over. How is that going to help? I saw, for example, for mortality measurements, somebody saying that 6 crores is a big grant when we possibly need that much per district. And this is one of the oldest things. So without the matching commitments and being put on this and WHO being defunded, developing countries must seize the moment, carpe diem, and actually come in to strengthen the WHO on this. But again, a large part of it due to the lack of alertness of the public health community, which is sort of engaged with local problems here and there and has no time for looking at the global issues, we really are falling behind. Brazil and South Africa is playing a leadership role in this. But India must pick up. So Articles 9 to 14 is on access to technologies. I'm just going to summarize in 2-3 slides so that we don't have things. 9, research and development. 10, sustainable technology transfer. 11, technology transfer, reaffirming the Doha Declaration, global supply chain and network, procurement and distribution. These are necessities, a roadmap of ensuring access to technologies plus the ability for domestic production of the required technologies is one of the foundational agreements, the pandemic. And why so many countries, this was the big fight over there. When WTO Dunkel draft was signed, most of the developing countries signed on. We were not very alert in many of the negotiations, but this time we have been alert as developing countries. That's a big we, especially the African group, and they have been able to force a number of these things put in place. However, there are contestations. The developed countries signed on only after they agreed to a term called as mutually agreed, which is put in the footnote. And as mutually agreed means for the purposes of the pandemic agreement, willingly undertaken and on mutually agreed terms without prejudice to the rights and obligations under other international agreements, by which they mean the trade agreements. Okay, so at some point the big compromise is, as far as private sector, developed countries participation goes, it becomes voluntary and not binding. However, in the flip side, it does strengthen and give a vision of what public sector could do. And I noticed that you have said resilience in public health services. And it gives a very clear 5-point things of what you should do to do, and the strengthening of WHO can play a role. So potentially a strong public health-led health sector can actually use the space provided in the pandemic agreement to build the health sovereignty and the health self-reliance and thing that you really need for this. Of course, the biggest area of confrontation is on this clause, Article 12, which is still the argument is going on, what is called pathogen access and benefit sharing. This happened during the flu pandemics. Every time the flu virus mutates, the countries of the West want to rapidly develop testing kits and vaccines and medicines to match the new virus. But for doing that, they need to get the virus from wherever country of origin well in advance of the pandemic reaching their shores. So Indonesia gave them the flu virus, but when they asked for some part of the vaccines on affordable terms, the companies refused. So Indonesia refused to give its vaccines. Since then, and with something called the Nagoya Protocol, the developing countries of the world are saying, we will share our biologic material and genomic sequence with you only if you commit to sharing the benefits of the products and technologies. They are not willing to do that, but we have also not compromised on that. So this contestation has become particularly sharp on that. On lockdowns, we have said very little, we've understood very little, and this is really an issue. So in summary, is the world safer? Not really. The developed countries are not on board. There is no acceptance of the principle of common but differentiated response, which is there in climate change. CBDR is a climate change principle. No binding agreements on corporates, no parallel measures to build up core capacities of under the IHR, progress to UHC facing barriers. So this is all the bad news. But there is grounds for optimism. It's not been a walkover. For developed countries, there has been contestation. There has been an acceptance of a new set of principles. There is a better understanding of why we are facing these barriers, and many countries are now got invested in developing their domestic vaccine technologies, their domestic biologic technologies, and there is a transfer of technologies among like-minded countries and the space to form a coalition like the BRICS coalition, You must read the BRICS Health Ministers meeting discussions to see where these are aligning to form an alternate system. So it's an ongoing process. And the battle has just begun, and potential to address many of the structural determinants of poor health and its outcomes. So public health is not just what you guys do in your villages and your primary health centers. Public health is a lot policy driven from the global level. And an intelligent engagement with global policy is a necessity for any country. You cannot just become your own success story. You do need changes in federalism, you do need changes in the global order, and somewhere what Rudolf Virchow, one of the fathers of public health, says that physicians are the natural attorneys of the poor. Public health community is the natural attorneys of equity of the poor, of the world we want to see. Thank you.
Thank you, sir, for your thought-provoking session about the Global Pandemic Agreement. Now, DPH Icon 2025 welcomes a pragmatic and conversant Additional Director Urban, sir, Dr. K.C. Seran, sir, to felicitate the speaker. Thank you, sir. Next, intersection point is where the past, present, and the future meet. Now, DPH Icon 2025 welcomes an avid official, the warrior behind COVID-19 pandemic in the city of Salem, the Principal Health and Family Welfare Training Center, Madurai, onto the dais. Dr. Parthiban, sir. He is moderating the panel discussion on Tamil Nadu Public Health Act 1939, the past, present, and the future. Now, I cordially invite the speakers, Dr. Madhivannan, Retired District Health Officer, Dr. Manivannan, District Health Officer, Ariyalu, Mr. Srinivasan, Technical PA, Sivagasi, Mr. Nihal Sahu, Research Fellow, the Vidhi Center for Legal Policy. Welcome, sirs, for the session. Over to our moderator, sir.
Respected DPHR, dignitaries of the dais, esteemed panelists, all the delegates, very good morning to one and all, and I welcome you all to this panel discussion of Tamil Nadu Public Health Act, the past, present, and the future. Tamil Nadu Public Health Act, the erstwhile Madras Public Health Act, was enacted in the year 1939 for the Presidency of Madras, which covered, apart from the state of Tamil Nadu, parts of Kerala, Karnataka, Andhra Pradesh, Telangana, and even some districts of Odisha. This act was enacted during recurrent epidemics of cholera, malaria, plague, etc., in order to contain those diseases and also provide sanitation, proper sanitary measures. WHO defines health as a state of physical, mental, and social well-being, and not merely absence of disease or infirmity, emphasizing that it is the holistic well-being of life. In a similar manner, when it comes to disease prevention, this act has rightly identified in 1939 itself that the domain of disease prevention and control cannot be carried out only by health department, and it needs involvement of other departments, particularly local bodies, food safety, environmental sanitation, etc. Hence, it empowered the local authorities as well as health authorities to act upon sanitation, water supply, and other measures to prevent public health. This act was a futuristic act way ahead of its time when it was enacted nearly a century ago, as most of the provisions of the act are still relevant now, and it will be relevant even in the coming many years. Because even in the modern era, disease prevention and control of emerging and re-emerging diseases plays a vital role, and it is directly linked with the development of a nation. This act covers varied aspects of disease prevention such as safe drinking water supply, sanitation and safe solid waste disposal, safe liquid waste disposal through public drains, food safety, mosquito control, prevention and control of infectious diseases. It even has provisions for preparedness for disease prevention during mass gatherings, given in the chapter of fairs and festivals. It even talks about nuisance and its abatement. It even provides for the finances needed, the ways and means of finances needed for implementing this act through taxation. This act, in contrary to the common belief that it is regulatory in nature, but rather it uses various approaches like directive and governance approach, mandating the local bodies for provision of safe drinking water and sanitation, service approach, mandating health service provision and vaccination services, regulatory approach, regulating trades and occupation, enforcement approach, wherein it enforces compulsory isolation and quarantine at times of outbreak, and legal and punitive approach in case of violations and non-compliance. This act, whenever I go through this act, it never ceases to amaze me of how far it was ahead of its time, and also how well thought through, how deeply thought through when it was enacted almost a century ago. This act played a key role in keeping this unique, distinct public health cadre of our state alive for this many years, which in turn helped in keeping the state as one of the front runners in case of epidemics and disease control, as evidenced our response during COVID-19 times, and also at times of floods and outbreaks, the public health experts from our states are called for and sent to nearby states like Kerala for guidance. They guide through and settle the issue and come back.
actually adversely affected the Public Health Act reformations in the subsequent years. It resulted in the situation similar to pre-enactment days of Madras Public Health Act. Because there is no debate and discussions among the expert committee members in the Public Health Board, the amendment on administration in urban local body of public health establishment has not been thoroughly discussed and debated. So just like that, they have passed the amendment. Similarly, unjustifiably, the sanitary officers are given the health officer powers because every local body has a executive authority and they are already empowered to enforce the Public Health Act powers. Police officers also unjustifiably enjoyed the Tamil Nadu Public Health Act provisions because they already have legal powers, similar legal powers under Indian Penal Code and Epidemic Diseases Act. Actually, the amendment of giving powers to police officers has not resulted in any additional benefits in COVID control situations. It just helped the police officers to make some easy money. Then any government authority or celebrity having extraordinary influence on the government can bring irrelevant amendments in the Public Health Act. That is the reality now. If you see the inclusion of cancer as notified disease under Section 62 of the Public Health Act, you can realize the thing. Then self-declared sanitation certificate through Tamil Nadu e-Sevai portal, which is recently introduced, has not been debated. Just the IAS officials discussed and they have decided. Because there is no clear-cut specific rules or norms, sanitary norms on each and every category of institutions coming under this sanitary certificate. Madras Corporation Municipal Act, MDM Act, and the District Boards Act. Since the executive authorities are the competent authorities to prosecute under Local Bodies Act, health officers had to depend on the executive authorities for taking all legal measures. Then sometimes the health officers had to take individual decisions which are disliked by the local bodies. So they become uncooperative and even they considered health officer post in urban local body as a nuisance and burden. That was the situation. And then government realized that the health officers must be given individual powers to act independently for the benefit of residents of local body. So, government enacted Madras Public Health Act in 1939. The indication of independency of health officers can be realized in section 9, 13, 14, 15 and 16 of Tamil Nadu Public Health Act. But contrary to these independent powers were eroded in 1989 by an amendment in section 13 and 14 of Tamil Nadu Public Health Act, and the whole public health establishment in urban local bodies were given to under the control of executive authorities. In 2023, even the health officer's unique status provided by Section 9 has been diluted by enactment of Urban Local Body, Tamil Nadu Urban Local Body Rules 2023. Contrary to the very purpose of enactment of a separate new law for health officers, all these amendments have been happened. And we must understand the mission of public health is fulfillment of society's interest in assuring conditions in which people can be healthy. But the fulfillment of society's interest become a pipe dream now because now the health officers in urban local bodies have to forget about the society's interest. They have to dance according to the tunes of urban local body authorities. Next, sir. Next slide, sir. Next slide. Next. I have selected few points, comparison between the past and present. Amendments were made and without distorting the core structure of public health in the past. Now, no one bothers about the core structure of the Public Health Act. If you take, for example, during COVID times, amendment was made in section 76(2) of Public Health Act. Previously, there were only 9 clauses in the act, in the section, but now there are 21 classes in the section. So, but this actually the amendment was badly needed during COVID times, but this could have been done by simply framing a COVID prevention and control rules under section 81 of Tamil Nadu Public Health Act without disturbing the core structure of the Public Health Act. Major communicable diseases like leprosy, venereal diseases, smallpox, plague, cholera were included in the Public Health Act as a chapter or subchapter or rules. I don't know whether anybody know about leprosy was provided as a subchapter in the Tamil Nadu Madras Public Health Act in 1944, and then it was deleted after the independence in 1948 because that's how, sorry sir, time sir, 3-4 minutes. So, next, but presently major diseases like NCDs, NCDs are not included in the Public Health Act. Then diseases directly relevant to core concept of public health alone are made as notifiable diseases. But now they don't bother diseases which do not fit in the purview of Public Health Act or do not come under direct responsibility of public health person can be made as notified disease. For example, snake bite and cancer. Similarly, disease control was based on no-in-adi concept. That is the root cause of the issue, especially through legal approach. This approach has given actually it showed the importance of public health to the policymakers and the public. But now the focus is more on the no-in-adi concept. that is management aspect of the disease, like medical camps, house-to-house distribution of ORS or DBC workers, that too mainly through service approach. Actually, the health officers has lost the image of public health guardian of the society now. Then the health officers have the image of legal and technical experts dealing with all public health issues of local body. So they have the unique position in the urban local body then. But now they have the image of a medical officer looking after routine functions of the public health functions of the urban local body. Lastly, originally started as sanitary department has become public health department and then become public health and preventive medicine department. But the way in which the Public Health Act is being implemented at present, they may become as preventive medicine department in future. Sir, one slide mattum, can I? Next slide. Last slide. Adukku munnadi sir. My suggestion is, first and foremost thing to be done is formation of public health board. That is, as I have already explained. Then the government, the DPH should apprise the government about unique status of the public health department, which is vested with policing powers. For example, arresting powers are given under section 140 of the Tamil Nadu Public Health Act. But this arresting power is not found in any local body act or medical acts. And then the administrative control of all health officer posts, including Chennai Corporation, should be brought under direct control of Director of Public Health, for better coordination during epidemics and public health emergencies. In fact, if this is not done, in future there is a tricky situation. The health officer, 1 minute sir. The public health department will be catering only about around 30% of the rural population in future because of the changing demographic ratio of state population. And then all modification sections, rules, norms and of Tamil Nadu Public Health Act should be in tune with the newly enacted health allied departments laws. Last thing, I think this is the most important point I want to stress. Block health officer posts should be created, or BMOs should be delegated with health officer powers under Tamil Nadu Public Health Act. Because if an executive authority without any medical background can enforce all the powers of health officer, if a sanitary officer with inadequate knowledge on medical subjects can enforce all the powers of health officer, if a police officer is not exposed to public health laws can enforce public health officers' powers, why not block medical officers should be delegated with the Public Health Act powers? Thank you.
Thank you, sir. Thank you for stressing the importance of absence of public health board and its consequences, and also the issues related to overlapping jurisdiction of powers, and the most importantly, the need for periodical introduction of rules and bylaws so that the act is kept relevant according to the current context. Now I welcome Mr. Srinivasan to dwell upon the current implementation, the ground reality and the challenges in implementation. I welcome you, sir.
அனைவருக்கும் வணக்கம். முதல் முறையாக எனக்கு இந்த வாய்ப்பு கொடுத்த இயக்குநரகத்துக்கும் இயக்குநர்களுக்கும் நான் வாய்ப்பு தெரிவிச்சுக்கிறேன். இப்போ சார் சொன்ன மாதிரி கிரவுண்ட் ரியாலிட்டியில் பப்ளிக் ஹெல்த் ஆக்டில் நமக்கு வந்து நம்ம ஃபேஸ் பண்ணிகிட்டு இருக்கிறது மெயினாக வந்து அது அதர் டிபார்ட்மெண்ட்டோட கோஆர்டினேஷனோட செய்ய வேண்டிய வேலைகளை வந்து பப்ளிக் ஹெல்த் டிபார்ட்மெண்ட்டில் இப்போ நம்ம வந்து கொஞ்சம் செய்ய வேண்டியதில்லை. அதுக்கு வந்து பீரியாடிக்கலாக வந்து நம்ம வந்து இன்டர்னல் டிபார்ட்மெண்ட் கோஆர்டினேஷன்ஸ் மீட்டிங்ஸ் வந்து ரெகுலராக நம்ம வந்து இன் கலெக்டருடைய தலைமையில் வந்து நம்ம நடத்தினோம்னா நமக்கு வரக்கூடிய பப்ளிக் ஹெல்த் பெட்டிஷன்ஸை வந்து நம்ம வந்து டிஸ்கஸ் பண்ணுறதுக்கான எளிதிலான வேலையை வந்து நம்ம செய்கிறது கொஞ்சம் ஈஸியாக இருக்கும். ஏன்னா அதுதான் இப்போ நிறையா சேலஞ்சஸ் வந்து நமக்கு வந்து ஃபீல்ட் லெவலில் எங்களுக்கு இருக்குது. எல்லா பெட்டிஷன்ஸுமே வந்து யாருடைய இம்பார்ட்டன்ஸ்னு தெரியாமையே வந்து நம்மக்கிட்ட வந்து அவங்க வந்து அதை பண்ணுறாங்க. பட் வந்து அதை வந்து சொன்ன மாதிரி நம்ம இன்டர் லெவல் டிபார்ட்மெண்ட் ஒரு கோஆர்டினேஷன் மீட்டிங் வந்து நம்ம வந்து பண்ணினோம்னா அதனுடைய பப்ளிக் ஹெல்த் ஆக்டினுடைய இம்பார்ட்டன்ஸ் வந்து அதர் டிபார்ட்மெண்ட்ஸ்க்கு நம்ம கொஞ்சம் அடிக்கடி நம்ம சொல்லிக்கிட்டே இருந்தால் தான் அது தெரியுது. இல்லைன்னா எல்லா பேர்டன்ஸுமே வந்து பப்ளிக் ஹெல்த் ஆக்ட் மூலமாக நம்மக்கிட்ட வந்துடுது. அதை நம்ம கொஞ்சம் சேலஞ்ச் பண்ணுறது கொஞ்சம் கஷ்டமாக இருக்குது.
சார் எனிதிங் யூ வாண்ட் டு இப்போ வந்து பெனால்ட்டி இம்போசிஷன் அதுக்கப்புறம் வந்து உங்களுக்கு லீகலாக போகிறது டைம் கன்சியூமிங் ப்ராசஸ் அதை பற்றி ஏதாவது சொல்லணுன்னா யூ கேன் டெல்.
சரி சார் ஆக்சுவலாக இப்போ வந்து நமக்கு லீகலாக போகிறதுல வந்து பை ஸ்டெப்பாக தான் வந்து நம்ம வந்து பண்ணிக்கிட்டு இருக்கணும். ஃபஸ்ட்டு இப்போ வந்து நம்ம யாருமே வந்து பப்ளிக் ஹெல்த் நோட்டீஸில் வந்து பேஸ்ட் ஆன் தி பெட்டிஷன்ஸ் பிரகாரம் தான் நம்ம வந்து பதில் கொடுத்துட்ருக்கோம். பட் அப்படி இல்லை. நம்ம பப்ளிக் ஹெல்த் நோட்டீஸ் பார்த்த உடனே நம்மளுடைய அந்த பிளேஸை வந்து நம்ம வந்து ஃபஸ்ட்டு வந்து இன்ஸ்பெக்ட் பண்ணி அதற்கான கிரவுண்ட்ஸை வந்து நம்ம வந்து ப்ரிப்பேர் பண்ணி வச்சுக்கிட்டு தான் நம்ம வந்து ஸ்டெப் பை ஸ்டெப்பாக போகணும். ஃபஸ்ட்டு வந்து நம்மளுடைய பிளேஸை பார்க்குறது, தென் அதுக்கப்புறம் வந்து நம்ம நோட்டீஸ் இஷ்யூ பண்ணுறது, எந்த டைம் பவுண்ட் கொடுக்குறது, இப்படிலாம் வந்து நம்மளுடைய இதை வந்து நம்ம டிசைன் பண்ணிட்டே இருக்கணும். பட் அது வந்து இப்போ நம்ம வந்து கொஞ்சம் கொஞ்சமாக வந்து நம்ம ஃபீல்டில் வந்து அது பண்ணிக்கிட்டே இருக்கோம். இருந்தாலும் வந்து அந்த ஸ்டெப் பை ஸ்டெப் மூவ்மெண்ட் வந்து நம்ம கரெக்டாக பண்ணோம்னா வந்து நம்ம பப்ளிக் ஹெல்த் ஆக்டில் வந்து கொஞ்சம் இம்ப்ளிமெண்டேஷன் வந்து ஈஸியாக இருக்குது.
Thank you, sir. Thank you for your insights in the current implementation and challenges in the field. Now I welcome Mr. Nihal to give his legal perspectives regarding this act, the past, and what needs to be done in the immediate future.
Thank you, Doctor. Most of what I wanted to say in terms of what needs to be changed in the act has broadly been covered by Dr. Madhivanan. I have 2 or 3 broad points to make, and I'll leave it at that. The first thing is that the act needs a radical set of amendments right now. It has been since 1939, and there have been a flurry of some amendments, most of them which are administrative, or most of them which are to do with the changing of the names of places and bodies. There hasn't been a rethinking of what the content of the act is based on what your present circumstances is. The Public Health Board, as I understand it, is not active. Most of the officers, as well as most of the activities that are taking place under the act, are not directly related to what the ground reality is right now. As in, for example, I don't think, for example, that the structure that is envisaged in the act, where there is a Public Health Board that sits and oversees and advises, where there are DHOs with very specified powers, as the doctor was saying, and where there are sanitary inspectors with a careful and narrow notion of how to do disease control. That is not what happens anymore, because it is no longer 1939. That needs to change. The question is, how will it change? We have 2 options broadly. We can amend the act and try to bring those things in, because it is in many respects a good piece of statutory legislation. Or you can do a broad-scale revision of the act and replace it and have a Tamil Nadu Public Health Act 2025 or 2026, which broadly replaces the act and tries to address all of our modern problems. Introduce a chapter on NCDs, introduce more information on maternity care, think about all the new disease control strategies that you're applying now, and think about what legal powers you need right now to enforce these. So you need a broad rethinking of the structure of the act. I think, in fact, you should do both. You should make an immediate set of amendments to try to modernize some aspects of the act, and in the longer term, you should have a committee that is constituted, and I think the government of Tamil Nadu should have a committee which is constituted with the broad goal of revising the Public Health Act for the future, and to broadly rethink our legal approach to solving these problems. I want to make one more point, which is broad, and then I'll leave it to Dr. Parthiban, which is that the point Dr. Madhivanan made about the importance of the DHO as an independent officer is fantastically important. And this is not about what the law says, but it is about having a sense of the rule of law. Because there is a notion, I think, today, because the act is so old, that it is not that important in the field. And when we've spoken to the DPH and when we've spoken to all sorts of officers in the Tamil Nadu, the notion is that we want to first get the act out onto the field and get it operational. And make the field officers more aware of their powers, more aware of the limitations of the act, and more aware of the manner in which the act contemplates things should be done. That cannot be done until the act is amended. But until such time, there is a notion that needs to be introduced broadly about what it means to have a functioning piece of legislation. Like the people of Tamil Nadu have elected a legislative assembly, and the legislative assembly has set out and said, this is how I want public health in my state to be administered. And they have set out a director of public health, and they have set out a series of officers broadly with independent authority to assess the situation, to act with broad-ranging police powers that kind of I've never seen before in broad legislation, to enter buildings, to take aggressive action, to close down residences, to ban types of work in entire sets of areas. These are broad powers that, aside from the police, only public health officials are generally expected to have, because it is such a fundamental function of government, and it's such one of the first functions of government, and it is one of the most cost-effective ways of improving the life of a people. So because of these reasons, a more direct sense of what it means to have a piece of legislation, and which really informs the way the field works, where every sanitary inspector and every DHO has a very intimate, real sense of their statutory authority, of their responsibilities, and of what they are, which is an agent and a function of the government of Tamil Nadu, and not a person acting merely on orders or implementing just programs. And I think that mentality is something that will take a long time to come in, and I think it's very important. That's about it. Thank you.
Thank you, Nihal, for bringing role clarity. One important point that I would like to ask from you, mainly legal consideration.
Yeah.
Whether, given the complexity of activities or enforcement that needs to be done in the field of public health, whether it will be possible to define roles and powers between departments. Like, as you have pointed out, the independence, also pointed out by Madhivanan sir, regarding the independence of health officers. But it needs to be interlinked to some extent with other departments, I have said in the beginning remarks itself. So what is the possibility of clearly demarcating these things in case if we are, I know that it cannot be done during immediate amendments, but when we are reenacting, what is the possibility of clearly defining powers without overlapping jurisdictions?
It's going to be very difficult because, for example, under the Urban Local Bodies Act and the Panchayat Act, there is a series of responsibilities that are public health related. Under all sorts of legislation, there are some public health related. Under the Public Health Act, there are things that, for example, should be under the Town and Country Planning Act. For example, there are jurisdictional disputes between the Director of Public Health and the Director of Town and Country Planning and so on. These things are built into the Act from a very old perspective. I think what you will essentially have to do is have an interdepartmental consultation and basically sit down and say, what is your sphere of responsibility? What is my sphere of responsibility? And try to, at a higher level, try to determine these issues as a matter of policy. I think a lot of what the Act originally set out in the Act will now have to move to rules. Specific activities like how you go about doing, mosquito control programs should not, I think, be particularly mentioned in the Act. I think the Act should set about a clear and broad frame of powers and a clear and broad frame of responsibilities and some limitations, and the rest of it should be left to rules, and it should be carefully drafted so that you have a very distinct sense of what will happen in this range and a very distinct sense of how different departments interact. I think there has been some contention between local authorities and public health departments as a general matter. And I think this is largely a consequence of having old statutory language. I think the government has to come out and say who will take what.
Thank you. Thank you. Now I welcome Dr. Manivannan sir to deliberate on the way forward going into the future.
Good morning, all. Legislative approach. So it's the first of its kind of act was passed some 85 years back. It dealt with disease control and prevention, sanitation, housing standards, food safety, public health authorities, enforcement and penalties. Have been recently amended, enacted sections and powers of the police to prosecute and deal with public health matters. So what's the role of our directorate? Initially, during the later years, the Directorate of Public Health is also entrusted to give primary health care delivery. So this became a primary health care delivery is a huge burden and a huge work. So many of us, the Public Health Act is of least priority. We remember only during any outbreaks or epidemics, this Public Health Act is remembered. And unlike other acts, Drug Act, they have an exclusive personnel to implement the act. They have no other work. Be it a drug inspector or a food inspector or a factory inspector or a labor inspector, their only job is to implement the act. But it is not so. We have multitasked our personnel. So Public Health Act is becoming where we thought it's of a least priority. We remember only during outbreaks. So in our mind, we generally think that the Public Health Act is more outdated because we enacted some 70, 80 years back. But it's really not so. Even in modern days, we think the NCDs outweigh communicable diseases. The sanitation issues are still a huge problem, even in urbanized, semi-urban, peri-urban areas. And the threat of communicable diseases is still large. Maybe it may be emerging or re-emerging. The Public Health Act, the uniqueness of this Public Health Act is a robust prosecution mechanisms. Even though the penalties have not been updated, it may be 5 rupees, 10 rupees, 100 rupees, still this type of a robust prosecution mechanism, be it a local body act, be it a country planning act, any act, this Public Health Act has a robust prosecution mechanism. And currently WHO is addressing the international health regulations, signing countries with various regulatory rules. But 85 years back, our Public Health Act has exhaustively dealt with the current international health regulations. So still our Public Health Act is a very efficient tool. Many other states have taken cue, be it Kerala, or Orissa, Gujarat, or Madhya Pradesh. They have enacted the Public Health Act in the recent years, and our department has been a model for the entire country for this enforcement of the Public Health Act. As I already said, many other Public Health Act deals with the public health matters, but for them, the main priority is not Public Health Act. Be it even the combined building rules.
So that it is contextual. Now, if there are any questions from audience, we'll take maximum 2 questions.
Required that the Public Health Act needs for implementation. Even carcass disposal. It's so sophisticated, so much fertilizer, so much productive, it's money to be made there. So I think that technical support. But the main one is the issue of entitlement.
I'll try to answer your question, sir. Actually, there is a colonial touch to the act because the name itself implies it was enacted in the colonial era even before the constitution of our country has been laid down. So the mindset of the colonial people is definitely there in the act, which needs to be amended, and the rights of the citizens and entitlements, public-centered approach towards this one, even service delivery, universal health coverage, all these things needs to be introduced into it.
Man learning. நீங்கள் போய் என்னென்னலாம் டிஃபெக்ட்ஸ் இருக்கோ அந்த டிஃபெக்ட்ஸை நோட்டிஃபை பண்ணி அதை அக்யூமுலேட் பண்ணி கொடுத்தீங்கன்னா there will be a change in the present policy. எதுக்கு நான் இந்த கொஸ்டினை எதிர்பார்த்துட்டு இருந்தேன், டிஹெச்ஓஸோ ஹெல்த் ஆஃபீஸர்ஸோ கேட்பாங்கன்ட்டு. பட் லக்கிலி நீங்கள் வந்து கேட்டீங்க டைரக்ட் இம்ப்ளிமெண்ட் பண்ணுறவர் இதில் பிஹெச்எஸ். அதனால் இதில் வந்து நம்ம வந்து ராங்கான இம்ப்ளிகேஷன் எடுக்காமல் if we wait for some time and if we have demonstrated that we have no vested interest, அதுதான் ரொம்ப முக்கியம். அது இந்த பாயிண்ட் வந்து எப்படின்னா எனி லாஸ், எனி என்ஃபோர்ஸ்மெண்ட் become vested interest of certain groups. இது not only in public health or health, any department, any country. Globally it is happening. But we have to demonstrate that we have no vested interest. It is in the interest of the public, we are doing certain, implementing the act. Abdin நம்ம demonstrate பண்ணும் பொழுது, the government will have some consideration of the policy and change the course. Right? This is on behalf of the speakers, I will.
Thank you, sir. Thank you all for your patient listening, and I thank all the panelists.
இந்த பாயிண்ட்டை பற்றி நான் ஒரு விஷயம் சொல்லணும்னு ஆசைப்படுறேன். பப்ளிக் ஹெல்த் ஆக்ட் வந்து இட் இஸ் எ ஜென்ரல் ஆக்ட். பார்த்தீங்கன்னா நீங்கள் இன்ஸ்டிடியூஷன் பேஸ்டு கிடையாது. அது ஸ்கூல்ஸாக இருந்தாலும் ஃபேக்ட்ரியாக இருந்தாலும் இல்லை எனி அதர் இன்ஸ்டிடியூஷன், நீங்கள் வந்து கொடுத்துருக்கிற அதே சானிடேஷன் ஆஸ்பெக்டில் இருக்கிற ஃபுட் சானிடேஷன், வாட்டர் சானிடேஷன், என்விரான்மெண்டல் சானிடேஷன் ப்ரொவிஷன்ஸ் இருக்குது. இல்லை இன்ஸ்டிடியூஷன் பார்த்தீங்கன்னா அதுக்கு தனி சாப்டர் இருக்குது, பில்டிங் அண்ட் சானிடேஷன் பற்றி. ஓவர் க்ரௌடிங் வரும். அப்போது நீங்கள் வந்து irrespective ஆஃப் இன்ஸ்டிடியூஷன், நீங்கள் இந்த ஜென்ரல் ஆக்ஷன், இப்போ ஸ்கூல்ஸ் எடுத்துக்கிட்டிங்கன்னா நீங்கள் ஏன் ஸ்கூல் அந்த ப்ரொவிஷனில் போகிறீங்க? ஸ்கூல் எஜுகேஷனல் டிபார்ட்மெண்ட்டில் ப்ரொவிஷன் வேணும், இல்லைன்னா நான் ஸ்கூல் மேலே ஆக்ஷன் எடுக்கிறதுக்கு தனி ப்ரொவிஷன் வேணும் அப்படின்னு பார்க்காதீங்க. எக்ஸ்ட்ரா பொலேட் பண்ண கற்றுக்கோங்க. தட் மீன்ஸ் இப்போ ஜென்ரலை வந்து இந்த இன்ஸ்டிடியூஷனில் எப்படி அப்ளை பண்ண முடியும், அதுதான் நீங்கள் புரிஞ்சிக்க வேண்டிய விஷயம் இந்த பப்ளிக் ஹெல்த் ஆக்டில். இதை வந்து இப்போ டேட்டூ பற்றி, டேட்டூ பார்லர் பற்றி கூட நிறைய டிஸ்கஷன் வந்துச்சு, இஷ்யூஸு. இப்போ திடீர்னு புதுசாக ப்ராலிஃபரேட் ஆயிடுச்சு. அப்போ எதில் ஆக்ஷன் எடுக்கிறது? இதுக்கு தனி ஒரு செக்ஷன் இருக்குது. பட் இட் இஸ் ஜென்ரல் செக்ஷனாக இருந்தாலும் நீங்கள் சாப்டர் 7 படித்து பார்த்தீங்கன்னா அதுக்கு ப்ரொவிஷன் இருக்குது. 60 வரும் செக்ஷன் 6, செக்ஷன் 62 பின்னு நினைக்கிறேன். அதில் வந்து ஸ்பெசிஃபிக்காக ஒரு சில விஷயங்களை கொடுத்துருக்குறாங்க. இது ஒரு பர்டிகுலர் இது வந்து ஹெல்த் ஆஃபீஸர் பர்மிஷனோடு தான் வைக்கணும் இண்டஸ்ட்ரி, இது அந்த ஒரு இது வந்து அந்த ட்ரேட் அப்படின்னு சொல்லி கொடுத்துருக்காங்க. அப்போ நீங்கள் அதை எக்ஸ்ட்ராபோலேட் பண்ணி பார்த்தீங்கன்னா எந்த இண்டஸ்ட்ரி ஹெல்த் ரிலேட்டடாக வருதோ அதை வந்து ஹெல்த் ஆஃபீஸர் பர்மிஷன் இல்லாமல் வைக்க முடியாது. அதனால் தயவு செஞ்சு எக்ஸ்ட்ராபோலேட் பண்ணுறதுக்கு கற்றுக்கணும். தேங்க்யூ.
What we usually see is the tip of an iceberg. But this session has helped us to visualize the iceberg, that is the Tamil Nadu Public Health Act as a whole. Thank you, sirs, for the session. I would cordially invite the organizing secretary of the DPH Icon 2025, Dr. P. Sampath sir, onto the dais to felicitate the speakers. Dr. Madhivanan sir, retired DHO. Dr. Manivanan sir, Ariyalur DHO. Mr. Srinivasan, Technical PA, Shivakasi. Mr. Nihal Sahu, Research Fellow, Vidhi Center for Legal Policy. Thank you, sir.
The unseen, unheard, and untouched public mental health scene is the much wanted subject for the present day India. DPH Icon 2025 cordially welcomes Dr. Naveen Kumar, Head of Community Psychiatry Unit, NIMHANS, to speak on public mental health scene of India. Is the tide turning? A few points on Dr. Naveen Kumar. Sir has been the member of National Academy of Medical Sciences in 2011, Principal Investigator in National Apex Coordinating Center. Sir has received SS Jairam Award, IPSOCON 2013 and Young Minds in Psychiatry Award, Professor Raghuram Distinguished Young Teacher Award. We welcome you, sir. Over to you, sir.
Hello. Thank you, ma'am, and I thank the organizers of the DPHI Con for having invited us to this important topic. The organizers have taken very good care of us, including Dr. Nirmal, Mr. Mahil Vannan, and Dr. Sriram and Dr. Saranya, and so on and so forth. And I also would like to thank the Department of Public Health, or the Directorate of Public Health, for having considered mental health as one of the important public health concerns. Mental health was always an invisible epidemic. Even during COVID, we saw what happened. So I would not like to stand between you and lunch. So I'll skip through the slides. Maybe I'll take about 10-15 minutes maximum to go through this topic. I am actually not a public health professional. I am a clinician. I see patients day in and day out in the hospital, but I'm interested in this public mental health or public health. That's how we have done some work with many underserved states of the country. First, in my first half of the presentation, I'll be talking about how has the public health scene of mental health in India evolved. And in the second half, I'll be talking about what work NIMHANS has done. Some specific data, state-specific data we will get in specific data. State-specific data we will get in National Mental Health Survey 2, which is currently underway. So the gap is 75 to 80%. That means that only 1 among 5 individuals who have problems, they have access to treatment. The other challenges are inequitable resources, longer pathway to care, and so on and so forth. So there is a need for task shifting and task sharing. So when you look at, this is the burden, but what has India done till now? In fact, India was one of the earliest countries to take up mental health as one of the public health challenges. Psychiatrists as early as 1980s. So that was when the 1982 the National Mental Health Program was born. The number of psychiatrists were there less than 1,000 at that time. A series of meetings. So the National Mental Health Program began in 1982, and these are some of the earlier publications that came in Indian Journal of Psychiatry. So after the birth of National Mental Health Program, the District Mental Health Program, the operational component, operational arm of the NMHP was conceptualized. The focus was in the district, the focus was in the service provision, capacity building, and awareness generation. So NMHP being the much larger component, it also has, in addition to the DMHP, NMHP has components of manpower development. Scheme A and Scheme B, it is called Center of Excellence and Strengthening of the Psychiatry Departments across the country. It includes monitoring and evaluation, training and research, daycare center for persons with mental illness, residential long-term, residential continuing care services, mental health helpline. These are the components of the mental health program of the country. So the first appraisal of DMHP occurred after about a decade of the birth of the National Mental Health Program. Support materials were developed. Mental health as a public health problem started to get discussed in the conferences. Development of the DMHP model occurred. Successful demonstration that primary care doctors could manage psychiatric problems, that was demonstrated by that time. Realization that objectives of the NMHP are too broad. Then the next 2 decades, it followed the global trend and community-based strategies. The district mental health program was adopted, as I said, as an operational arm. It started, the DMHP started, in 1996 with 4 districts. Then it got extended to 27 districts, then across the states and union territories. By 2010-11, about 100 districts had an operational DMHP. So in 2012, there was a serious review of the policy group of the Government of India, which looked into critically what has happened to this mental health. So there was very wide variation in the performance. Large gaps existed. South and West had better DMHPs at that time. The services were present mostly the district hospitals, outpatient district units. Little involvement of the ground level health staffs. So that is when the human resource development was strengthened, the Scheme A and Scheme B that I was talking about. So in the past 10 years, there have been a rapid expansion.
That is what I mean to say when I say the tide may be really turning. When compared to the past 40 years, the last 10 years has seen significant development at the national level. I'll tell you why. Because the DMHP has expanded to over 700 districts of the country. At least on paper, DMHP is operational. Components of DMHP, National Mental Health Policy has come in 2014, which talks about universal access to mental health care. Somebody was talking about universal health coverage. And so in alignment with that, the National Mental Health Policy also talks about universal access to mental health care. In fact, a couple of states have come up with the state level mental health policy. For example, Meghalaya has already, based on this, has come up with state mental health policy. I know state of Maharashtra is working on the state mental health policy for the state of Maharashtra. Likewise, many other states also are coming. Reducing the risk of suicide, protection from harm and respect for rights of persons, to reduce stigma and so on and so forth. There are so many objectives of the National Mental Health Policy. And these are the guidelines under which the NMHP is functioning now. It's a very elaborate guideline. You can see the allocation for various issues under this under the National Mental Health Program. You see the manpower development, manpower details that are approved at the district levels, at the CHC level, at the PHC level, and so on and so forth. These are the list of psychotropic medications that ought to be present at various levels. And this is the direction on the public-private partnership as well. So next is the Mental Health Care Act. There was a wonderful discussion on the public health care of Tamil Nadu just previous. You could see the gradual increase in the number of patients that they were able to identify and pick up and treat at the primary care level over a period of 1 year. This was a 1-year course. And we also did some work with the prison medical officers, the prisons of Bihar. Here also you can see the number of patients that were seen, the skill level increased from 63% at 6 months to about 75% at 12 months after the training. And about 8% of the patients who were seen in prisons, they had psychiatric problems. The trained doctors were able to identify and treat them. This is an example in the state of Chhattisgarh. The footfalls you could see. Chhattisgarh, we are working for the past 7 years. The footfalls have in the primary care clinics has risen from 70,000 in the entire state to about 7 lakhs in the past, in the next 5 years. And this is one impact that I would like to state. And in the state of in the state of Uttarakhand, we have had an MOU with AIIMS Rishikesh and the government of Uttarakhand. We three are working together to improve the training of primary care doctors at the district levels, both in Bihar and Chhattisgarh and Uttarakhand. We can proudly state that there are actually NIMHANS trained doctors providing service in all the districts, especially in Chhattisgarh. All PHCs, there are more than 2,000 PHCs are there. In every PHC, there is a NIMHANS trained doctor delivering mental health care service. As regards the impact, after 1 year of training in Uttarakhand, approximately 11% of outpatients in the PHCs are identified to have mental health problems. And these are some of the other publications that was there. To talk about NIMHANS Digital Academy, it was inaugurated by the Honorable Health Minister in 2018. Currently, we are offering 34 courses, 7 diplomas and 27 certificate courses. In fact, NIMHANS Digital you can see the number of professional enrolled till now has crossed 1,75,000, out of which about 1/3 are accredited from various diplomas and certificate courses. And this is just the doctors' number enrolled are about 18,000 and
among the CHOs also. Of course, the range is very wide, but that is an impact that is 5% to 29% increase is what I would say. Next, I would talk about now the district mental health program is there. We need to move towards Taluka mental health program, because almost 95% of the districts are covered with DMHP. So we need a model for Taluka mental health program, and Ashrayas Trust is one a trust that has come forward to fund this. We are working with NIMHANS as the hub and AIIMS Rishikesh as a sub-hub. We have taken We have taken 2 talukas and we have had a very good impact till now. About 2 years we have been training. You could see the treatment gap has reduced from 90 to 60% in one taluk and from 93 to 53%. Just like that, suicide rate has reduced by 20% in 1 year. The clinic footfalls has increased in the clinics of this Naman. And National Program for Climate Change is another program in which NIMHANS is closely working with all the states and the central government. Some of the IECs that have been developed. Telemanas, as you all know, it has started from October 2022. More than 26 lakh calls have been serviced till now. More than 2,000 professionals have been trained. More than 530 on-site trainings have occurred. And there are actually some barriers which we are trying to work out. So in the last 2-3 slides, one is the public mental health. When you consider public mental health of India, this is my personal opinion. I'm subject to change. I believe that change is possible. Sustained efforts are required from multiple stakeholders. It could be health administration at both state and district levels, trainees, incentivization, trainers, constant monitoring, innovative methodology, patience and perseverance. There are both opportunities and future prospects, I would say, establishment of more regional digital academies, conversion of clinical beds into teaching beds across many mental hospitals in the country, AI-driven support, integration of service delivery through Telemanas and district mental health program, research and monitoring framework, and development of composite mental health indicators. These are some of the opportunities and future prospects. I'd like to end, by stating this. Thank you.
Thank you, sir. We can understand the phenomenal work done by a single institution for the in the community perspective.
Yes, sir.
Because what a PHC can do, tertiary care institution cannot implement. Similarly, the vice versa. So now I can understand that you have rightly pointed out that change is possible. And the patience and perseverance. Now we can see once the district mental health program is implemented, particularly in Tamil Nadu, our experience, people started responding to the availability of physician.
Yes, sir.
Because we are sending them invitations.
Yes.
Similarly, the Telemanas,
Right.
everything we are doing.
Yes.
But do we have any specific message to the primary health care physicians who are here? You can tell it as a suggestion or advice or whatever it
Yes,
is
sir.
to improve. Because intending psychiatric drugs, suppose if there is no response is minimal, the wastage of resources will happen.
Right.
So what type of intending, can you just brief?
Yes, sir. A couple of sentences. Thank you very much for bringing up this. We have been working with primary care physicians across the country, and it has been repeatedly proven for the past 50 years that at least 20 to 30% of the patients who come to the primary healthcare clinics, they do have psychiatric disorders, but they go untreated. That is point number one. There are very easy methods of identifying them. There are actually doctors in primary care settings, they clearly know this person does not have any other medical issue, but they struggle to manage them. That is why they keep getting repeatedly patients come back again and again, the drips and other things and Bantac and things like that. So if our primary care doctors are able to identify psychiatric problems, it could be somatization, it could be anxiety, it could be mixed anxiety, depression, substance use. These are the commonly prevalent problems in the primary care settings. They do come with multiple bodily complaints. So there are very clearly identified methods of treating them. That is point number 2. Point number 3 is the psychotropic medications. They are intended. I take your point. It is kind of it should not go waste. But the primary care doctor should know that the response is a bit low. I mean, a bit slow. What I mean is that once they start a low dose of psychotropic medications, they have to wait for at least 3 weeks or 4 weeks or 5 weeks, which the quick fix solutions are not there for mental health problems. And once they persevere, and once they patiently persevere, then the changes will come. And there are methods. They could actually contact the NIMHANS Digital Academy. We have designed courses for primary care doctors. which can empower them and help them identify these problems and treat them very well. And once the functional treatment gap at the primary care centers are reduced, then the treatment gap also will reduce. This is my message.
Thanks for your words, sir. We would look forward to have our doctors
sir.
trained, at least through online.
Absolutely.
And
It is
have
online course only, sir.
Yeah,
Advanced
yeah.
is,
Because we want to make it very structured.
Yes.
Because everybody, we have 6,595 doctors, 7,000
Okay.
doctors with us.
Okay.
In the primary health center alone.
Okay. Okay.
So if they get an exposure.
Absolutely.
And we would look forward to work
Absolutely.
with you.
We will be very welcome, sir. Thank you very
sir.
much.
Thank you.
very much.
Thank you, sir, for sharing your valuable insights. DPH Icon 2025 cordially welcomes Dr. Nagarani Madam, Additional Director, Department of Public Health and Preventive Medicine, to honor the speaker. We welcome you, ma'am. Thank you, ma'am. Now we moving on to the next session. DPH Icon cordially invite Dr. Manju Rahim, ma'am, Director, ICMR VCRC, to speak on malaria updates on new vector control tools. Madam will join us in online. A few points on Dr. Manju Rahim, ma'am. She has been distinguished medical scientist and public health expert, establishing national good lab practice, certified facilities for insecticide testing, enhancing research capabilities at both VCRC and the National Institute of Malaria Research. Advocated for the inclusion of DEIC salt in the National Lymphatic Filariasis Elimination Policy, and the use of PCR in malaria diagnosis as a programmatic component. We welcome you, ma'am. Over to you, ma'am.
It's not in the presentation mode.
You are audible, ma'am. Please go ahead, ma'am. We welcome you, ma'am. Ma'am, go ahead, ma'am.
Ma'am, is there some internet issue? I could hear a lot of echo.
Ma'am, is the slides visible?
Hello? Hey, but I could just hear a few background noises and some echo. I can talk. And somebody will move the slides? Okay, sure. I'll be fast. Thank you. Good afternoon, everyone. And I understand the time is short, but I'll try to make it as crisp as possible. I thank the organizers for inviting me, especially Dr. Senthil for pursuing this with me for this presentation. And the topic which was assigned to me was the new vector control tools for malaria control. And as we all know, it's in elimination mode. So the first slide which I'm showing you are there is this paper published by my group. And we were working on the new tools, and this is a review, not only on malaria, but all the vector-borne diseases, and what are the challenges and how can we resolve those challenges through the new tools. But if we restrict to malaria, we can see there are 6 major primary vectors of malaria, and you are well aware they are spread all across the country. So we do face a very large burden of vector-borne diseases. Next. Next. Yes. So there's nothing, yeah. So the current challenges of the malaria control and elimination will be dealt in the slides. And the next, we can go to the next one, no problem. Okay, next, I'll come to the problems now. So we have, okay, just 1 second. I just want to talk about the burden of malaria so that the people have the context. Okay, fine. If we see the history of malaria from 1950, everybody is well versed how we have progressed from a very high burden of 75 million cases now to around roughly 2.5 lakh cases. But as we move towards elimination, and the target is not even a single indigenous case of malaria should be there. And these are the milestones on which our national program has moved ahead. And we are in the time of 2027 to 2030 is a time when we should be going for verification of elimination, and 2027 should be the time when we should have 0 indigenous malaria case. Next. So if you see what is the situation, again we are tracking the trend of the reduction in malaria from 2000 to 2024. There was an 8-fold decline in malaria cases. Vivavax malaria declined 10-fold. Falciparum has decreased 7-fold decline. And there is a decline of 11-fold in overall mortality, that is the deaths due to malaria. But if we see from 2021 onwards, there has been a sustained increase in malaria cases overall for the country, and that I put up in the box in the graph. That also can be attributed to a better surveillance system of the country, and through IHIP portal, a better reporting also is there. But there is an increase in malaria cases, there is no doubt. There is almost an increase of 58% in overall malaria from 2021 to 2024. Next. So what are the current tools which are used for malaria control? They are majorly use of the insecticide treated bed nets, and they are treated with synthetic pyrethroid. Another is use of indoor residual spray. Again, they make use of synthetic pyrethroid or malathion. You are well aware that DDT also was used, but now it has completely phased out in 2024. So that is not being used anymore. And larvicide also are used for environmental management and through for the source reduction. Next. So what are the challenges and how do we counter those challenges for malaria control? So the biggest challenge which we will face is insecticide resistance. For that, we will require maybe new molecules with a different mode of action. We can have next generation insecticide treated nets. We can have attractive toxic sugar beds, which is still in research mode. We can have endectocide, and we can have newer newer tools like insecticide paints. There is a challenge of outdoor biting. There has been a subtle change in behavior in the malaria vectors because of the continuous use of LLINs and IRS molecules. So the mosquito is biting outside and is biting early. So that is leading to outdoor transmission of malaria. So what to do with that? So we can think about insecticide treated materials or wearables which people can use when they are going outdoors, like they are forest goers or if they are sleeping outside, they can be used. Special repellents can be used in closed and semi-closed spaces even if the mosquito is biting early and the people are not under
WHO Salem, UHC team, Dr. K. Krishnaraj, JD, NCD, Dr. T. Praveen, DPO, NCD and NCD team, Dr. P. Sambat, Additional Director, DC and PHC, Dr. N. Yoganand, DHO, Athur, Dr. M. Sandal Kumar, JD, DC, Dr. R. M. Shankarmani, HO, Dr. K. Vinay Kumar, JD, Immunization, Dr. B. Kanakabala, HO, Dr. S. Nandini, MO, Dr. K. Vinay Kumar, JD, Immunization, Dr. B. Kanakabala, HO, Dr. S. Nandini, MO, Dr. K. Vinay Kumar, JD, Immunization, Srimanta, and Dr. M. Sandal Kumar, JD, CD, Dr. P. Baluswamy, DHO, Coimbatore, CHO, Salem, Mr. Varadarajan, Regional Entomologist, Virudhunagar. இவர்கள் அனைவரும் மேடைக்கு அருகே குழுமுமாறு அன்புடன் கேட்டுக்கொள்ளப்படுகிறார்கள். மாண்புமிகு அமைச்சர் அவர்கள் வந்தவுடனே மலர்கள் வெளியிடப்படும். மேடையில் வலப்புறமாக மேடையில் ஏறி மலர்களை பெற்றுக்கொண்ட பின் மேடையின் இடப்புறமாக இறங்கி மேடையை விட்டு அகலுமாறு அன்புடன் கேட்டுக்கொள்ளப்படுகிறார்கள். இந்த வரிசையில் வாசிக்கப்பட்ட அனைவரும் மேடைக்கு அருகே மிக விரைவில் குழுமுமாறு அன்புடன் கேட்டுக்கொள்ளப்படுகிறார்கள். நன்றி.
JD's additional, please come to the stage.
வருடாந்திர சர்வதேச பொது சுகாதார மாநாடு நிறைவு விழா காண்கிறது. விழாவிற்கு தங்கள் அனைவரையும் பேரன்புடன் வரவேற்கிறோம். மேட்டூர் அணையும் சேர அரையன் மலையும் சங்ககிரி கோட்டையும் தாரமங்கல சிற்பமும் பெருமை சேர்க்கும் சேலத்தில் நிகழும் DPH ஐகான் 2025 4வது சர்வதேச பொது சுகாதார மாநாட்டு நிறைவு விழாவிற்கு வருகை புரிந்துள்ள பல்துறை அறிஞர்களுக்கும் DPH அன்பர்களுக்கும் செங்கதிரோன் ஒளிபரப்பும் சேல பெருநகரின் செழுமை வணக்கங்கள். தங்கள் வருகையால் பெருமகிழ்ச்சி அடைகிறது DPH ஐகான் 2025. அவையோர் அனுமதியுடன் நிகழ்வை இனிதே தொடங்குவோம். தமிழுக்கு வணக்கம். மலைகள் சூழ் சேலம் மண்ணுக்கு வணக்கம். தமிழ்தாய் வாழ்த்து பாட வருகிறார்கள் சேலம் மாவட்ட கல்வித்துறையின் இசை ஆசிரியர்கள். DPH ஐகான் 2025 4வது வருடாந்திர சர்வதேச பொது சுகாதார மாநாடு நிறைவு விழா காண்கிறது. நிறைவு விழாவில் பங்கு கொள்வதற்காக அமைச்சர் பெருமக்களும் ஆட்சியாளர்களும் வந்து கொண்டிருக்கிறார்கள். தொடர்ந்து நிறைவு விழா நடைபெறும். தமிழ்தாய் வாழ்த்து.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் வதனமென திகழ்பரத கண்டமிதில் தெக்கணமும் மதிர் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
பின்னால் நின்று கொண்டிருப்பவர்களுக்கு தன்னார்வலர்கள் இருக்கை அளிக்குமாறு அன்புடன் கேட்டுக்கொள்கிறோம். நின்றுட்டு இருக்கிறவங்களுக்காக சேர்ஸ் அரேஞ்ச் பண்ணுங்க வாலண்டியர்ஸ் ப்ளீஸ். முன்னாடி ஃபஸ்ட்டு 2 ரோ விட்டுட்டு அடுத்த ரோக்களில் அடுத்த வரிசைகளில் வந்து அமருமாறு எல்லாரையும் கேட்டுக்கிறோம். முதல் 2 ரோ விட்டுட்டு அடுத்த ரோக்களை ஆக்குபை பண்ணுங்க. DPH ஐகான் 2025 4வது வருடாந்திர சர்வதேச பொது சுகாதார மாநாட்டின் நிறைவு விழாவில் வரவேற்புரையாற்ற மாநாட்டு அமைப்பு செயலர் கூடுதல் இயக்குனர் DC and PHC பொது சுகாதாரம் மற்றும் நோய் தடுப்பு மருந்து துறை அன்பிற்கினிய மருத்துவர் P. சம்பத் அவர்களை அன்புடன் அழைக்கின்றோம்.
அனைவருக்கும் மதிய வணக்கங்கள். செப்டம்பர் 25, 26, 27 ஆகிய 3 நாட்களில் இனிதே நடைபெற்ற 4வது சர்வதேச பொது சுகாதார மாநாடை நடத்தி தந்த அனைத்து நல்ல உள்ளங்களையும் வணங்கி என் வரவேற்புரையை தொடங்குகிறேன். முதலாவதாக இந்த மாநாட்டு நிகழ்வினை சட்டசபை அறிவித்த நமது அமைச்சர் அவர்களுக்கு முதற்கண் நன்றி தெரிவித்து